Okay, a very good morning to all of you that have joined. I see our participant numbers are rising quite rapidly. So I'd like to welcome you to our second webinar for FEM. And a big thank you to Sayosh for hosting this webinar for us. So while our participant numbers are going up, I just want to run through a few rules very quickly. So from the previous webinar we did, we get quite a lot of inquiries around the CPD points. Please remember that these are SIOSH CPD points. And if you are registered via SIOSH, you will receive your CPD points. From the FEM side, we do not give any CPDs, nor do we give any attendance certificates. I spent a week answering emails on that. And just in terms of the proceedings for today, we have one slight change where we'll be swapping two of the speakers. That will be Jimmy and Sean, sorry. So I will keep you abreast of that as we go along. Now, before we start, I just want to remind you that this is quite a long session. It is around 3 hours long. I'd encourage you to stand up and move around and not sit in the same place for 3 hours. We also have the chat function opened. So if there's any questions that you'd like to pose, you can do it on the chat forum. But before you share a question, I'm going to encourage you to please have a listen to the presentations and check that your question hasn't been answered. And if it hasn't been answered and you do have a burning question, then you're more than welcome to put it onto the chat. There's a very high number of questions that come through the chat, and we can't get through all of them. We do have a few people that are overseeing the chat, but we might miss one or two questions, and for that we apologize up front. If we do miss your question and you still require an answer to it, we encourage you to email us. You'll see contact details on the screen, or you can get onto our website, which is www.fem.co.za. And if you go onto our news desk, you'll find all the webinars placed there. There's also contact details where you can get a hold of us individually, and you can get a hold of myself if you still need the answers to those questions. So before we start, I still have about 3 minutes before I call on Ndeboa to do the official welcome. I'm going to play you a video just to put FEM into context and to share some of the benefits of FEM. So
Hi everybody, Safety Sipo here. Did you know that in 1936, FEM was granted a special license by the Minister of Labour to provide workmen's compensation cover to any business that falls in Class 5, which is the industrial rating of the construction sector. So, if your business falls under this class, you can join FEM as a policyholder and enjoy great benefits like access to private healthcare for injured employees, ensuring treatment is in line with the injury and avoiding overservicing by utilizing a group of professional nurses called MSO who closely monitor treatment of injuries. We also do all the administration work for you, including requesting of all relevant reports until finalization of claims, leaving you time to focus on what you do best. Our online submission of claims documentation helps to speed up the process of claims. We also have detailed accident stats on our website for you to access at your convenience. To further assist, we lodge a claim on the employer's behalf with the Road Accident Fund for motor vehicle accidents. Finally, we offer on-site training for claims and underwriting around the country on request. I trust that I have managed to highlight the benefits of joining FEM. Should you want to find out more about our dynamic company or how to join FEM, please feel free to contact us via any of the contact points on your screen now. Thank you for your time and attention. For FEM, this is Safety Sipo signing out.
Okay, that was just a quick video on the benefits of FEM. And moving along, I'm going to introduce you to our first speaker, which is our CEO, that's Ndebo Manyonga. She will now do the official welcome. Thanks, Ndebo.
Thank you, Herman, and welcome to everybody. As Herman indicated, my name is Ndebo Manyonga, and I head up the Federated Employers Mutual Assurance Company. And it's a real honor to have all of you on our second webinar as part of this series where we are focusing on COVID-19 and the construction industry. I'd like to also extend my gratitude to Niels and the SIOSH team who are hosting this webinar with us. We do have a good relationship with SIOSH that extends beyond just hosting webinars for one another. You know, they are a grant recipient of ours at FEM in terms of assisting us with health and safety initiatives within the industry and beyond. It's also good for me to also express my gratitude to IOSH UK. I'm aware of the fact that they did extend this invitation to their members throughout Africa as well. And it's great to see that you know, we've got a number of people representing different stakeholders who are participating on this webinar. Safety Sipo did give you an overview of who we are as FEM. I thought it's still worthwhile to just highlight a couple of things, especially for those who might not be familiar with who we are. We have been around since 1936, so we are almost 85 years in existence now, and really a strong legacy within the construction industry in terms of providing workmen's compensation cover. We currently cover more than 5,000 construction companies, and this ranges from those that are listed on the stock exchange, larger players, to the smaller players as well. And across our base of employers in the construction industry, we cover more than 300,000 employees. We have our head office in Johannesburg, but we do have regional offices also in Durban and Cape Town as well. We've got a very keen interest in COVID-19, especially because as a provider of workmen's compensation, we do cover COVID-19 as an occupational disease. But I think just generally, and maybe just from positioning perspective as to why we wanted to host the specific webinars, I think it's fair to say that COVID-19 has had an unprecedented impact on all of our lives. And in particular, and more relevant for today's webinar, it's had a great impact on the world of work as well. You know, the International Labour Organization estimates that as at the end of June, more than 93% of workers across the world were in some form of lockdown or other. And that has further translated to obviously an increase in unemployment and underemployment as well, and the added challenge around securing the health and safety of workers in the workplace. South Africa is obviously not immune. We've got our own local study, the NIDS-CRAM survey, which is the biggest study of its kind outside of the health studies that are being conducted, that is looking at COVID-19 and its impact. And locally, you know, when our own lockdown was implemented at the end of March going into April, more than 3 million people reported through the survey that they had actually lost their jobs. And the reality that COVID-19 has further highlighted is that there are a lot of inequalities that exist in the world of work. So if you look at that loss of employment that has happened within South Africa, the reality is that it has disproportionately impacted on the poorest 50% of our population, where 30% of them reported that they were unemployed during the lockdown, and a further 9% reported that they were furloughed. So by furloughed, we mean that they were employed, but they were not receiving an income. How does that translate further from an inequality perspective? You will see on this graph in particular that manual laborers reported that 24% of them lost their jobs as a result of the lockdown as well, and a further 11% were furloughed. Even more so in terms of reinforcing some of the inequalities and possibly taking us back in terms of the gains that we had made from an employment perspective. Women were also highly impacted by the lockdown, and disproportionately so compared to their male counterparts, where 26% of women reported that they were unemployed as a result of the lockdown, compared to 11% of men that said that they were unemployed as a result of the lockdown. So that inequality being reflected from an unemployment perspective, but also translating to the impact in terms of health and safety of employees. I mean, a lot of us are fortunate to be able to have the opportunity to continue to work from home as COVID-19, is impacting our ability to go into the office. But there are a number of people, and unfortunately, I suspect that, with the same type of distribution that we're seeing here in terms of impact of unemployment, similarly, you would have found that a lot of people who are involved in manual labor had to go back into the workplace because there wasn't any other way in which they could continue to earn an income. And that is specifically relevant in the construction industry. Our industry was able to resume work with effect from the 1st of June and the advent of level 3 lockdown within South Africa, which was a great outcome and a hard fought for outcome. We know a lot of industry players and stakeholders came together to lobby government to reopen the industry, an industry which could ill afford COVID-19 because it was already in a bad space as we got into 2020. So with that excitement of reopening and the ability to get back into the workplace, it came with a lot of anxiety also and a lot of effort around reflecting on how can we collectively as an industry ensure the health and safety of those who actually need to go back into the workplace. And the unfortunate reality is that we have seen instances of COVID-19 outbreaks on construction sites. We see those stats and that data on a regular basis because we obviously provide workmen's compensation for the construction industry. And my colleague, Jacqueline, shared some stats at our first webinar last week in terms of what we are seeing from a claims perspective. At that time, she had reported that as at the end of the prior week, we had seen about 49 claims that we had received coming through from our policyholders. As at the end of last week, that number had increased to 62 claims that were received across our policyholder base in relation to COVID-19. And I think the distribution of those claims received to some extent reflect the distribution of COVID-19 and its incidents across South Africa as well. And I think we are preparing ourselves for the fact that the construction industry is increasing in activity. And that increase in activity is definitely going to come with an increase in claims as well and incidents of COVID-19 outbreaks on construction sites. I think it is worth us actually casting the spotlight on COVID-19 because it is a serious and it's an unprecedented event that is forcing all of us to really rethink how we deal with health and safety in the workplace where workers are concerned. And it is fair to say that it's something that we can't overcome by ourselves. We do need to work together to come up with the different types of solutions to protect the health and safety of workers. And while we do that, the one thing that we need to ensure is that we do not lose sight of the fact that the world of work was already a dangerous place for some workers, even before COVID-19 came into effect. And in focusing our efforts on COVID-19, we must not lose sight of the need to continue to work on ensuring the general health and safety of workers in the workplace. And I just thought I'd just reflect on this slide as well, which I also shared last week. That just reinforces the point that I made around the world of work being a dangerous place, especially in the construction industry. Even before the advent of COVID-19 this year, as at the end of June, we had already received claims related to over 2,000 accidents within the construction industry in South Africa, and that's across the policyholder base that we cover. So those additional COVID-19 claims that I referred to in my previous slide are over and above these claims in particular that we'd already received. And sadly, we also had 10 fatalities within the construction industry as well. These statistics are available on the FEM website, www.fem.co.za. And I would encourage you all to please go in and look at those statistics. You can carve them out in different ways, and they reinforce concerns that we have highlighted, across the years in terms of some of the trends that we see around health and safety of construction employees, and in particular, looking at things like motor vehicle accidents being one of the key areas where we've got a concern in terms of it being a key contributor towards accidents in the workplace. As an example, we see about 9.2% of our total accidents are attributable to motor vehicle incidents in the workplace, and that compares unfavorably to global statistics. And I think it's a clear reflection of motor vehicle accidents being a scourge in our society in general from a South African perspective. So once again, just to reinforce that we do need to continue to focus on this. As I'd indicated, this is the second in a series of webinars that we are conducting during the month of July. The first one we hosted on the 23rd of July, and I've just put up the topics that were covered then. These topics and the presentations are available on the FEM and the SIOSH website as well. Today's panel of speakers, we've got a great lineup, and Herman will introduce each and every one of them as they come along, and we're so grateful to them for having put their hand up to participate in this process and to give of their time in terms of providing very, very valuable insight and input on what is a very topical issue within the construction industry and beyond. So thank you very much to Dr. Claire Deacon, who is the managing member of OcuMed, Jimmy Quinn, who's the elect president of IOSH UK, Sean Chester, the technical director at Apex Environmental, and Kobus van Veengat, who's the national SHEC advisor for SAFSEC. Thank you to all of you for your presentations in advance. And I'm sure all of the people who've dialed in for today's webinar are waiting to hear from the experts. So I will not take up any further time from my perspective, and I'll hand back to you, Herman.
Thanks for that, Ndebo. Okay, there are a couple of poll questions that we're going to pose to you as an audience, but in the interest of time, we're going to do this after our first speaker, which is Dr. Claire Deacon. So just a little background to Dr. Claire Deacon. She's the managing member of OcuMed CC. Dr. Deacon has practiced in the field of health and safety since 1982. Claire Deacon and Associates, CDNA, commenced in 2008, trading under OcuMed CC. CDNA is an associate of Coalition Trading 517cc, trading as Construction Research Education and Training Enterprise, which is CREATE, with Professor John Smallwood. Claire obtained a general nursing diploma at Groote Hospital and qualified in occupational health at the University of Stellenbosch. She has completed various degrees, a BTech in occupational health at Peninsula Technikon, BSc Med Honours in Ergonomics at the University of Cape Town, and a Master's in Nursing MCOR by Research at the University of Port Elizabeth, UPE. Claire was admitted to the prestigious Research Capacity Initiative, the RCI, with the South African-Netherlands Partnership for Alternative Development, that's SANPAD, which was completed February 2006 cum laude. She has completed a PhD Construction Management at NMMU entitled The Effect of the Integration of Procurement, Design and Construction in Health and Safety. Dr. Claire Deacon will be talking to us about linking COVID-19 risk and exposure at work. So without further ado, welcome Dr. Deacon.
Thanks, Sanjay. Morning, everybody. Nice to see a good number of my colleagues in the participants. Hello, Eastern Cape, among other. And thanks very much, Sanjay, for the invitation to discuss. When you talk about my resume, I always think that's all I've done is it appears to be studying, but I suppose life did happen in between. So without further ado, I'm going to talk about COVID, and I'm just going to share my screen with the presentation. So the way that I've looked at today's presentation really is about risk and exposure at work, but also in terms of mitigation from a very practical perspective. Those who know me know I'm very practically orientated, and I like to bring in things in terms of quite a different way of looking at things. So I hope that this will resonate with everybody in some way or another. And please feel free to give me a shout if you need some more information or anything. And obviously, Sanjay, I assume that this presentation will be available to participants. So just by way of introduction, my very good colleague, Professor Theo Haupt, always says you need to see the end at the beginning. And obviously, to FEM, I was quite interested because when on your stats at this point in time, because you have no kind of cases that have been actually accepted from what I can see, it almost appears when you don't see any statistics that there's no problem. So I'm really pleased to hear that there have been some claims, but obviously the issue is, how do you then, ratify those claims in terms of them being seen as an occupational disease through exposure? So the idea is that we need to try and mitigate the end result, which is obviously people who are going to contract COVID at work. The other thing is I'm just going to look at some of the links in legislation. I'm not going to go into that in any major detail, but I think it is important just to look at those from this perspective and where they link in. And maybe I know that a lot of health and safety officers and managers, etc., look at the construction regulations in isolation when they look at health and safety, and you can't do that, especially now in terms of COVID. And then of course the need to undertake risk assessment and all the other documentation that goes with it, and then that need to link those two aspects to limit exposure. And I put a bit of practical stuff in that. I work in the field and I work on the ground. So what I've seen on my projects, and I must be honest, I've been quite impressed with what a lot of the health and safety officers and the site teams have put together, and how they've come up with ways to try and limit exposure to workers, and how to make it as safe as possible. And of course the other aspect, which I know that my colleagues and I really enjoy, is I've never seen such a clean site or clean sites ever, and I've never ever gone around and seen as many hand washing facilities and whatever around the portable toilets specifically. So there's such an upsurge of that, and that's been probably, for my mind, one of the most incredible upswings and positive issues that have come out of this whole process. So I'm just going to look at the legislative framework quickly in terms of what we've looked at. And I know that in our audience here, we have some people who sat with me. As some of you know, I am the Executive Director of the Association of Construction Health and Safety Management at CASM. And through that, we are part of the Construction Rapid Response Task Team. And we, during lockdown, worked really hard with a good couple of our colleagues to put together a guideline which was submitted for public comment to the Ministry. It was Minister of Employment and Labour, and also, of course, Public Works and Infrastructure. So we have to first of all look at the Constitution and then obviously the Act itself. And we're not only looking at the construction regulations here, but also the hazardous biological agents regulations, which under which the Disaster Management Act is invoked. Of course, in terms of this particular case, we're looking at the COIDA, but we also cannot, because the whole issue around COVID is also one of managing people, and the health and safety aspect forms part of the suite of documents around labor relations and about people. We have to also then include the Basic Conditions of Employment Act. The Disaster Management Act itself, obviously, and then under that, the various COVID-19 health and safety measures in workplaces and the various directions and so on. And I'm sure that we'll probably still see a few more documents coming out from time to time regarding how that all plays out in managing health and safety in the workplace. We've already had, a further direction in terms of that C19 OHS document. And that basically just guides us. And, although those documents are largely generic in nature, in other words, that they're expected to apply to any particular environment, we have to take them and put them into the construction sector and put them into into something which is perhaps a little bit more meaningful around that. And we're happy to share that document. It is in the public space in any event, the document that we put together for the Construction Rapid Response Task Team. Then the Act itself, I just basically broke it down into the various sections, which I think are the most important ones. And again, I'm not going to belabor these. I do think that under Section 8, the duties of the employer are quite, specifically and well, kind of articulated around what the duty of the employer must be. And from a construction health and safety agent point of view, we often have a lot of, I won't call them arguments, but a lot of debate about terminology in the sector where the employer and the client, the terminology is interchangeable, and depending on the type of contract that is being used, have different meanings. But in this particular case, the duties of the employer is somebody who employs people under the Labour Relations Act, and there is a relationship in that. So, the duty of the employer then has, or the employer has specific guidelines and requirements to identify risks and mitigate them. And then to look at how that's going to be enforced and discipline if it doesn't happen. So, it's a very simple cycle that needs to be followed in terms of that particular section of the Act. Then the other real one, I think, is obviously duty to inform and general duties of employees, which is also kind of encapsulated in the various directives of the COVID-19 from the Department of Employment and Labour. And then the incorporation of, health and safety reps and committees, which I think is a really important aspect, and I think an undervalued one. And I must say, not so well. When I've done audits, and we do COVID audits on site, or include them in our agent audits, I find, in my perspective, that the health and safety managers and officers don't really look at that as well as they could. I think there's a lot more that could be done around COVID in those two areas. And then obviously in terms of Section 24 and 25, around the reporting and so on, around the inspector, and of course then reporting COVID as an occupational disease, if you can find the relationship between work and the individual contracting the disease. So I just wanted to remind everybody of what the definition is under the Compensation Act, the COIDA. It's an accident arising out of and in the course of an employee's employment and resulting in personal injury, illness, or the death of an employee. So the critical thing is that there must be a link between the employment and then the whatever it is that individual contracts, and sadly in many cases the fatality may die from that. And in particular around COVID, there's no, a person could certainly die, very quickly from COVID, from contracting COVID. And I can now change this next statement to say there are no stats relative to COVID at work in the construction sector. And I look forward to seeing, Sanjay, that those stats are updated on your website. And you know that I also, every now and again, when we talk at other conferences, I would like to see more occupational diseases actually being recorded in your statistics, because I do believe that generally, I think that we know that there's underreporting of occupational diseases generally, but I think people think that there's no problem, you know, and if we're not reporting the silicosis or the mesotheliomas and all of those other diseases, then people don't think that they're a problem and they don't actually address them or take them seriously enough in the workplace. So the updated legislative requirements broadly now, in terms of the documents which were published through the lockdown stage 4 and 5, were a range of issues, and they have been clarified and expanded upon by the Department of Employment and Labour. And I'm sure that in time to come, if we are still in lockdown, you know, for a fair amount of time still, which I have a sneaking suspicion we're still going to be, and that means then that there may be other requirements we need to do. So obviously this is not a definitive list, and it will change from time to time, and everybody would need to apply their minds from a perspective of how they're going to apply these requirements into their particular circumstances. I think the other issue is that in terms of these requirements, they are company-based and not necessarily project-based around COVID. So, for example, if you have, I'll just use that as an example. I have 2 projects where WBHO are the principal contractor, but I'm not going to necessarily expect all of those documents. For example, the submission of the risk assessment and policy to the Department of Labour from a project perspective, but I would like to see that the documentation that was submitted, or evidence of that document being submitted, is from WBHO itself, and that a record of that would be on the project. So as an example, so obviously if that is only limited to employers of more than 500 employees, but I think that I hate to say this in certain cases, because I know Reynard Leach is in the audience too. The law is an ass in certain cases, and obviously with minimum or legal minimums doesn't necessarily mean that it's better practice or that it's optimum or it's going to actually address the issue. So I think that one needs to, from an organizational point of view, or from a practice point of view, or from a project perspective, whichever way you decide to do it, or whichever way you are going to kind of look at the whole picture, you need to identify and look at how it would be best suited to you on your project to be able to limit and to link those risk factors and identify what those risk factors, so that you're going to best be able to protect your employees and workers and your contractors on your projects. So the first thing is obviously the risk assessment and a policy. Yes, by all means, go and, if you are from a large organization, or maybe it is your organization, you know yourself that what you can measure, you can manage. So I think it's very important to identify what those risk assessments are. And I actually will go into a little bit more detail on that and show you how we've actually, from the professional, the PRCHSA perspective, looked at some of the risks as they apply to the project. And that was some of the work that we kind of expanded on from the work we did with the Construction Rapid Response Task Team. And similarly to the policy, you need to provide guideline to your staff and provide leadership. Then the Health and Safety Committee issues, again, I think that they're understated in terms of their role. I think the old adage of more eyes on the ground, the better. And people will be people. In most cases, I've found that the contractors have issued staff with their own kind of small bottles of sanitizers. And so on, and generally across sites, I haven't found a shortage of those kinds of issues. But your Health and Safety Committee members and the Health and Safety representatives are certainly best placed to try and kind of ensure that their teams and the people that they're working with and they're responsible for are able to identify and use those sanitizers and wash their hands and take those kinds of protective measures. Then the vulnerable workers, the comorbidities, those who've got, serious chronic diseases that are not necessarily work-related, but will have an impact on the individual's ability and the risk factor of actually contracting COVID. And obviously we know that, I mean, COVID is an influenza type disease, virus. And obviously we know that, you know, if your resistance is low, if you are diabetic or hypertensive, then you are more at risk. I mean, and that's really what they have really highlighted in all of the documentation, are those risk factors which are, you know, which are going to put, you know, very obese workers, or, you know, people who have got, you know, diabetes or hypertensive or any other, there might be, you know, cancer patients, you know, being on chemo. You know, you don't, the last thing you want is to have those individuals at, you know, at risk. So those need to be looked at and considered. Communication. You know, it doesn't have to be fancy. You know, for a couple of $100 rand, buy a laminator from Macro or wherever, or Game or wherever, and then just laminate your own personal stuff. I think it adds a lot more, you know, kind of realism than going out and buying. I love it when I see that the health and safety officers and managers have, you know, taken the time to actually draw up documentation on site that is talking to their staff members and to their team and the culture on the site. And then the various compliance officers, and there are 3 particular ones, but again, you know, you say 3, I hate numbers in terms of these processes, because I think that it doesn't necessarily mean that those are the optimum ways of addressing things. So I would say that, you know, the more eyes on the ground, the better. Health and safety officers, and I know some other contractors have appointed students as COVID monitors. So you want somebody, you know, normally we would appoint the 8-1 as a COVID manager, and then the health and safety officer lands up being the officer. And then we appoint, I ask them to appoint a couple of monitors as well to take care of you know, other sort of on the ground issues and make sure people are maintaining social distancing and so on. And then minimizing people at work. You know, again, do you need to be at work? Can you work from home? And obviously that comes with its own risks and its own issues. But I think that, you know, I think that there's been a lot of positivity around that aspect. And then I'm going to look a little bit about the role of the client from a construction regulation perspective. Now, the way that I look at this, in the way that we've been doing quite a lot of workshops with the South African quantity surveyors, and also with the Association of Construction Project Managers on these kinds of issues, because they represent, you know, the client side, but often the QSs actually work for the contractors as well. But there is a way that we need to look at what the role of the client is in terms of the construction regulations. And the most critical thing to see in terms of COVID-19 is not necessarily that it is only you know, part of the hazardous biological agent regulations, but also that you see it as a significant design change, because it is a significant risk to the project. So if one says, okay, well, you know, I've got a 5-story building that is being constructed, and all the health and safety documentation from both the client and the principal contractor and their teams are, you know, are looking at that particular document. Now the client decides they want to go and put another 2-story building just adjacent to that. It's a complete design change. It might not be the same project, and it needs to basically start from scratch. There has to be a whole range of revised documentation that goes in, and new designs, etc., that goes in to look at that particular document. And I've been strongly recommending that individuals look at COVID like that, because it might next time not be COVID, it might be something else. I don't think these problems are going to go away. So we need to then, in terms of that evokes then Construction Regulation 51R, which says that from a particular design change, we have to go back and look at developing a further baseline health and safety risk assessment, and then from there look at the health and safety specification, align a bill of quantities that is linked to that design, which then takes us back into stages 2 to 4 of the project, or 1 to 4 in terms of project. And then obviously the issue then is to get the principal contractor then to provide a revised health and safety plan, which is then relative to those new changes and guidelines around that. And that includes obviously a bill of quantities in terms of costing. Now, obviously, from a costing perspective, that doesn't give everybody free rein to go and charge for everything that you want to go and charge for, but rather that it looks at, you know, what are those, what they call extra overs in the quantity surveying scenario. And we will be assisting the QSs with putting together a program in terms of that, to try and manage that, because obviously there are still things which the principal contractor in his own right as an employer needs to comply with in terms of his legal compliance. And then obviously there are issues where I think from a risk perspective, it's in the interest of the client to actually pay for some of those issues so that you know, they are better protected in terms of their role. So I've covered some of that already. Then the PRCHSA would approve and monitor them through the stages. And then, you know, that whole process is cascaded. So again, the whole point of this issue here is to make sure that COVID-19 is focused on as a significant risk on the project, and that potential areas of risk are looked at in terms of that, and then they're managed through the project. So this is the Zimbersky time safety influence curve. The sooner we do that, the better. And for my PR colleagues out there, William and Rob and Priscilla, I see you in the audience. There might be more I didn't see. The earlier we start this in the beginning is beginning. And for those of you, even if you are working as an officer or manager, go and have a look at John Gambatti's work. It just talks about designing for health and safety, or designing for safety as they call it in the States. And the sooner you start and get involved in the project and in terms of those processes, the better. And this just shows that there's very little you can do from a costing perspective if you are only looking at the documentation in stage 5 or once the project has actually started. And we have identified through the task team a whole range of high-risk activities that could certainly impact on the risk to employees of contracting COVID. Obviously, the one is the lack of financial resources. And not enforcing those financial resources in terms of project as required in the construction regulations, where it says that every single project must be resourced. And that goes for contractors too. They're expected to resource their projects for their contractors as well. So it's quite important to look at that. It's not just a client issue and a principal contractor issue, it's also a contractor issue. Transportation is a really big issue. And of course, I'm sure that many of you are just as worried as I am about the fact that taxis can, are 100% full. Well, then I suppose I flew, backwards and forwards to Cape Town a few times already in this last month. But then I'm kind of feel relatively satisfied that certainly the filtration systems in the plans are okay. But you can't necessarily say that you're not going to be sitting next to somebody who is potentially positive and doesn't know it. Then the manual labor, the tasks that people are doing, how close they are to each other in proximity, because that needs to be looked at from a task perspective, and obviously officers and managers are best placed to look at that with your teams in terms of the types of jobs that are going to be done on projects and how workers would be expected to work together, and are you able to, in those tasks, separate them so that you can link in with the at least the 1.5 meter gap. Of course, workers arriving at work, and I think there is a culture. I must be honest, I don't think that workers today, there's kind of an opposite scenario, I think, around coming to work. If they don't feel well, they don't come. But not everybody who's COVID positive has a temperature. So, it's not necessarily that they have many symptoms or they know that they've got symptoms. So there is obviously that risk of coming to work and contracting it in terms of that. And then, of course, the isolation and tracing, I think that certainly what I've seen on sites, they've done quite well. Ablution facilities, like I said, I've never seen such clean sites, and I've never seen such clean eating areas or around, ablutions, that there's actually, for once in our lives, actual opportunity to go and wash your hands when you've gone to the toilet. So clean welfare facilities, lunch breaks, and places where they can rest. Confined working areas, obviously those need to be taken into account and need to be assessed. Sharing of utensils and food, which is common among workers from a Ubuntu perspective, and I understand that, but I think it's really important from a personal hygiene perspective that we don't allow that anymore. Of course, the emergency supplies and so on, and then of course the that constant looking at exposure to work. And I think that colleagues, without any disrespect, most of you have got little idea about what occupational health really is in the workplace, to look at health issues and to kind of link them to what people are doing, around the particular type of PPE or the typical type of occupational disease which would be linked to that particular level of exposure. So I found this, which I thought was really interesting, and I thought it would be quite good in terms of the factors that influence the risk, and the 3 Ds, distance, dose, and dispersion. Obviously distance, you know, the 1.6 meters is the minimum distance, but does not necessarily mean that somebody won't still be infected even if they have got social distancing. And then obviously the dose, you know, the closer you're working together and the greater the time, you know, obviously there's an increased risk of exposure. And then obviously, you know, the size of the particles that are being coughed or you know, sneezed or whatever are going to have another effect. Obviously, fortunately, I think one of the perhaps positive things is that construction generally happens outside. So, you know, in the sun and in the wind. So, you know, there is a greater, well, maybe a slightly lower risk when you're doing civil and certain levels of building projects. But if you're getting into top structures and you're going inside the building, then obviously that, you know, becomes a greater risk from that type of construction. So what are some of the solutions? I've included here some of the, you know, the photographs that I've taken on some of my sites. To rotate, to stagger, include shifts, which is not always, again, necessarily a great issue, and brings with it other you know, problems. And then obviously off-site work, which also has some challenges. So the photograph on the left is a little isolation room. The contractors have been quite good in doing that. That was actually just basically, there was nothing in it. But, you know, we then spoke about it and said, well, how are you going to, you know, actually make this work if you find somebody who's going to eventually arrive on site who is perhaps positive? You know, there was no table or chair. And so just keep minimum, you know, issues. The less you've got to clean and the less you've got, you know, contact, the better. And then, of course, on the right, you know, it's been quite interesting how creative some of the contractors have been around providing hand washing and sanitary facilities. Now, this is a type of baseline risk assessment that we've put together. This is just really the upfront page, the baseline risk assessment for a particular project. And I'm a very practical person. I keep things exceptionally simple. And I think because, you know, we have you know, such a diverse workforce in South Africa, and I'm very aware that anybody should be able to pick up a risk assessment and make some level of sense to it. So I use just a 1/3 multiplier. So it's a 3/3. And then, of course, I also do a residual risk assessment. And the residual aspect of those issues then becomes part of what we include in the health and safety specification. So you can see what we look at here as the headings, just the aspects, and that's normally what is applicable on the project, what the hazards and risks are, and then what the control measures are to risk, you know, to look at the baseline raw risk, and then to look at what the mitigation measures are, and then to re-risk it. So that's just basically it. So what we looked at here was just PPE, and I looked at those, and you'll see that in certain cases, you know, what we all taught in terms of doing risk assessments is that you should try and, you know, reduce your risk by at least 50 to 75%. And in this particular case, we're doing that, but the risk still remains high, and the risk always remains high. And I had a contractor ask me once, well, why is the risk then still so high, even though you've put all of these factors into place? And really, the critical thing for me is the fact that you cannot control individuals' behavior 100%. You know, we all fiddle with our masks, and we put them down and we stick them under our chin, and, you know, that means, and then you forget to sanitize your hands, and you know, or you forget your sanitizer, you know, in your bag or whatever. So the critical thing is that, you know, how do you then, you cannot take away the risk entirely in terms of this. So these are some of the things that we've put into place. And again, some of you who've worked with me know that I'm the method statement queen. And I believe that the core document is the method statement. That is a technical document, and the health and safety documentation in terms of the contractors' risk assessments, and then all their safe operating procedures and their DSTIs, etc., follow from that particular document. You cannot manage what has not been stated or has been developed through that whole process. Okay, I'm still on time. So the next one looked at origin of labor. Excuse me. one of the things that we found from the origin of labour is obviously people transporting, and that's why I put these two on the same page. The origin of labour and obviously transportation of labour really do go hand in hand, because again, you know, one of the things that the majority of our general labour don't have, and that's the luxury of social distancing. It is a privileged thing, and if one has to look at it from that perspective. So you have very, very high densely populated, you know, places of you know, residence for most of our workers. And of course, in terms of them getting to work, they are obliged to use public transport, taxis, etc., or travel, you know, on the back of an open, you know, vehicle or whatever to, you know, to get to the place of work to feed their families. So I think that there is a really important and hence the Department of Employment and Labour's focus on trying to organise that contractors apply and supply transportation specifically to people. But then again, you know, people might be travelling with more than one set of vehicles, so they're going to be picked up at a particular point, but they've still got to get there. They're not going to be, you know, it's not going to be picked up from home. So it's important to check and perhaps for contractors to negotiate with taxi services or bus services or etc. to you know, to transport their workers as safely as possible, and to make sure then that they're protected while they're on that you know, on that vehicle. And of course then, you know, sanitizing vehicles. I had a case, in fact I should have shown the photograph, which was actually quite horrendous. One of the civil contractors who was doing some surfacing of a road, and they had a vehicle that would probably carry about 30 people in it. And all they were doing was putting one of those foggers in it at the end of the day, and that was their sanitizing. But the vehicle was absolutely filthy, and, you know, there was no distancing inside the vehicle when they were, you know, working. So it was a major issue around, you know, dealing with that. So I said, you know, I'm going to stop the work, you clean the vehicle, and you give me an updated documentation with regards to how you're going to do this. This is really not acceptable. Because again, you know, from a claims perspective, the issue is, how do you then as a principal contractor or a contractor protect yourself against a claim, or even the client from protecting a third-party claim? You know, if we didn't actually then monitor and make sure that those aspects were being, you know, monitored and measured. So the items in the residual risk assessment will give you some of the ideas of how we've looked at trying to mitigate those risks as much as we can. Obviously, you still can't, you know, do that entirely. And then site preparation, I find, is generally quite well done. You know, around preparing the site, I don't think that there were too many problems, and I think that this now will be, you know, a lot easier when sites are starting up. Then just to give you some, just a guideline, this is the type of thing that we've taken from the directive from the Department of Employment and Labour, and this is just a recent one we did where we assessed what the documentation was that was on site, and you can see the items in blue were relating to the management. So the risk management aspects were on the left-hand side of your screen, and again, the other issues there were, you know, how do you then link and you know, try and limit those risks of people then contracting COVID on the site. So social distancing, you know, again, an audit is only as good as the moment you're looking at it. You know, it doesn't really kind of extend beyond that. It's like when you're doing medical on an individual, you're only really taking a snapshot of that particular moment in time when you were there. You cannot actually, you know, do much more than that. So those issues there, again, report to COIDA if a positive case is contracted at work. Obviously, that would then also mean that it needs to be investigated as an incident or an accident. And then monitoring issues, those things are ongoing relative to, you know, how you need to monitor that. And I think the idea is, like you do with any particular job that is working, you need to make sure that you are, you know, constantly aware. And the more you read, the more, you know, webinars you go to, the greater your knowledge is going to be, and the greater you're going to be able to manage the risks and look at them from a health perspective, an occupational health perspective, to protect your workers from a greater degree. So again, in this particular case, we need to look at the operating procedures, PPE, the HIRO. You know, I look at the documents and I look at the links between the documents. And you need to do the same. If you're going to be putting together these documents for your contractors, then you need to be doing something in a very similar manner. Your method statements, your HIROs, your safe operating procedures, etc. They all need to look at those issues. There's such a dearth of information around there. You don't have to use expensive, foggers and so on. The NIO has got the most amazing information available, and they've got all the dilutions and all the different types of products you should use. It is not going to break the bank. And many of the contractors, the small contractors, they're not going to go and put in tunnels, which are not really, kind of required in any event. They're not recommended in any way. All right. So here's just a couple of photographs again. I think it's my last slide. Is the hand washing facilities. It's a pump one. You can see the bin next to it, all the notices up on the wall. And the contractor's taken his shutter boards in the middle photograph, and he's actually created little areas so that workers have got their private space to have their lunch or their teas. And then on the right-hand side, on this particular case is, well, that's where we can link with ergonomics and also social distancing in this case, where they are lifting a 90 kilogram 1 meter curbstone, which needs to be done in a particular way. And obviously in terms of this particular operation, they are less than 1.6 meters apart. So, they need to be wearing their masks, and you need to then engage them in terms of what it is that they need to do in order to be able to do that particular operation, or any operation. You need to go and assess each of those operations and decide, how safely they can be done. Yeah, I think that Sanjay is the end of my presentation. Yes, so I hope that you found that interesting. It's quite a different way of looking at things, and I hope that it helps you identify where those risks are, particularly looking at the issues where people are most exposed and how you can actually mitigate those risks going forward.
Thanks, Claire. Thanks for that very informative talk. I just have to set the record straight here. It's actually Herman.
Oh, sorry, Herman. Sorry.
It's an Indian thing, don't worry.
Don't see you. Oh, there we go. Herman, I can see your name.
Claire, very quickly, we are over time. There are a few questions that have come through. So if you can give me the shortest possible answer, I would appreciate it. So the first one is there a difference between the Osha officer and the COVID-19 compliance officer?
It doesn't have to be. I think it just depends on the most appropriate person for the job. And I think often it is the most appropriate person, because the health and safety officer is on site and is able to answer those questions. If you want, Herman, I can. There isn't actually. I don't see it here where there is where people are answering questions, and I can just answer them.
Yes, you can click on the chat button, and the chat will come up on the side. You'll see the questions on there.
So I'm happy to do that if you like, and then obviously those answers would be available to everybody.
All right, I've just got one or two more. In terms of first aid, is there any training guidelines specific to COVID-19 first aid training?
No, I honestly don't think that there really is. I think that obviously the critical thing is around obviously resuscitation, because obviously, and the same with occupational health around the SATS, the South African Thoracic Society, saying that we can't do lung functions and peak flows and anything where it forces an individual to do to breathe out to maximally to check the volume of their lungs. So I think that the same with breathalyzers and so on. You need to use common sense in terms of those processes, but it's not other than that I suppose there would obviously those individuals need to be more closely monitored, and obviously their PPE needs to be perhaps a little bit. I would maybe add an FFP2 mask or an N95 mask for them to use. That would probably be the only thing. And yeah, it depends obviously on what the circumstance is, but it would form part of what the health and safety officers need to look at around the risk of the types of injuries that they are likely to get on those sites. And I mean, it's quite easy, you know, from your stats, they can quite easily look at what the types of things happen in their particular type of environment.
Yes, 100%. Well, Dr. Deacon, thank you so much for your time. We really appreciate it. I'm going to move on now. And if we do have some time, there's a few more questions I might pose to you at a later stage.
Thanks, Herman.
Okay, moving very swiftly on. So I did mention earlier that there will be a slight change to the program, and this is where the change comes in. So we're moving Sean Chester a bit later, and we're going to bring in Jimmy Quinn. Jimmy Quinn is...
Poll question, Herman, poll question.
Sorry, my apologies. We are going to run a poll question. So I'm gonna ask Garrett to put up the first question, and while I introduce Jimmy, we'll get the results in on that.
Launching the poll now. Thanks, Herman.
Okay, so the first poll question we're asking is, please indicate if your organization has knowledge of COIDA requirements to submit a COVID-19 claim. So you can go ahead and answer. Garrett, when we're at about 60 or 70%, you can stop the poll.
No problem, Herman.
Okay, going on, I'm going to introduce Jimmy Quinn, who's the elect president at IOSH, and he's going to talk to us about ensuring workers' safety and health in the post-COVID-19 world. Just a little bit about Jimmy. After a very successful 24-year career in the British Army, James attained the rank of warrant officer. He left the Army in 2011. In his final 6 years of Army service, he began to appreciate the benefits of health and safety as a second career. Using his Army appointments, he started to train as a health and safety advisor/trainer in 2006. 5 years later, having worked on many Army health and safety projects, he joined Babcock International PLC as HSE trainer, then advisor, before becoming a health and safety manager for a large Middle East transport group. He then became area OSH manager, Abu Dhabi for Multiplex, and is now health, safety and environment manager for Multiplex's Chelsea Barracks construction project in London. Before I hand over to Jimmy, I'm just going to check with Garrett. Do we have the results of that poll question?
Coming through now, Herman.
All right, so if we look at our results, we asked, please indicate if your organization has knowledge of COIDA requirements to submit a COVID-19 claim. And we had 75% of participants saying yes, and only 26% no. Thanks for that, Garrett. On to you, Jimmy. Welcome. Thank you for joining us all the way from the UK. So I'm going to switch off my video and hand over to you.
Thank you so much, Herman. Very kind of you, and it's absolutely wonderful to be here and joining you all at this moment in time. I just want to make sure that everything's going okay on the slideshow. Is that okay?
James, if you can just go to the first section of your slide. I see you on slide 23.
Well, I was doing some revision.
No problem.
And does that all look okay as it is just now, or do I need to fix it some more?
No, if you can just make it full screen for us right there, that's perfect. You can carry on now. Thank you.
Wonderful. Thank you, everyone. Absolutely wonderful to be here, everyone, and thank you so much for that great introduction. I just wanted to quickly say, before we move on, the introduction was very, very good. Thank you. And basically, I'm now the president-elect for IOSH, and I'm actually looking forward to my year starting. I think that's me ready now in October, where I take over from the charismatic and fantastic Andrew Sharman. Big shoes to fill, and as Herman quite rightly said, I'm now moving. I moved away from Army in 2011 and found myself into health and safety, and I've been very, very lucky and very, very blessed in the last 10 or so years to be in this amazing career that I find myself today in construction. It's absolutely wonderful. In terms of myself as president-elect going forward, there's going to be sort of 4 pillars for me going forward, which will be young people, well-being. Notice I didn't say health and well-being. Well-being, we do a lot of health, and veterans, and the second career and first career for young people coming into health and safety. And I'm sure those are some of the challenges that we're going to have this year, and I'm sure that's something that we've probably looked at around the world globally, trying to get Osha professionals to take this on as a first career. In fact, I met a very charismatic young man when I was in South Africa a couple of years ago. I can't remember the chap's name, but taking Osha on as a first career, amazing. So what are we then? So what is IOSH? Well, IOSH, as a lot of you probably know, are a not-for-profit organisation, and we hold the charter, the Royal Charter. We have over 48,000 members and associated members across the globe in about probably 135, 136 countries. Seen as a thought leader, we underpin everything that we do by research, expertise, and understanding around the occupational safety and health world, and it's something that we spend a lot of time in. Again, membership organisation with over, what it says 47, but I think it's over 48,000 now. And we're an enabler, and we want to try and help organisations around the world to excel in safety and health. And I know that IOSH are very happy to be here today speaking to you all. So, the IOSH response to COVID-19. You know, in terms of the COVID-19 response, I believe that IOSH have done very, very well, and we have weekly webinars. And some of those weekly webinars are going down into branch webinar or branch meetings now. And COVID-19 is everywhere in everything that we talk about IOSH. And we're also trying to provide our network of over 2,000 training providers as well, and really trying to get that information out there. And since the pandemic was announced, we've really gone to town and trying to get as much information out to everyone. And you can see one of the slides there was the managing workplace safety and health in response to COVID-19, and that was Andrew that really kicked that one off. And you can see some great people in there: Dr. Andrew, Dr. Maria, Dr. Andy, and Dr. Ivan as well from the World Health Organization. And we've really tried to involve a lot of stakeholders and really push that message forward. So what is IOSH returning safely? Well, IOSH returning safely, as you're all aware, is probably trying to get back to work after the lockdown. And you know, with the lockdown itself, it's created a lot of anxiety and a lot of problems. You know, I can go into what I'll talk about later on, but trying to get people back to work or people to want to go back to work, there's so many different caveats to that. You know, it's not just a case of putting on your PPE, getting on a train, getting in the car and going to work. It's all those things in between. It's all those anxieties of people that have got wider families, that have vulnerable persons within the family, have problems now because the schools have all stopped, childcare can't happen, crops can't happen. There's lots of different caveats to this, to managing temporary workers, getting to work, how you're getting to work, and what do we need to do for those people returning to work? Do we just expect them to turn up at work? And do we expect them to come in? Are we going to do an induction? Are we going to set out the guidelines? People that have been on furlough, and I don't know how the furlough scheme has worked in South Africa, but it's been working very well in the UK, but that's going to start coming to an end. So you may have people that have been working for a lot longer and people coming back from furlough, which is going to cause anxiety in itself as well. So there's so many different caveats to this and a lot of other things that we need to think about, apart from the physical part, but also looking at the mental part of it as well. So what are we in terms of the OSH? You know, IOSH Returning Safely Hub. And this is a great hub for letting people know what we should be doing. And it focuses on the safe people, which again is focusing on what we are doing when we get to work, how we get to work, how we control things like workloads, how we control things like timelines, because we're going to see a lot of people coming back to work and returning safely that are probably going to be taking on more with less. And we're going to see a lot of companies struggling to get people together, to get the same output as they had with the same people, but with less people. But you're going to see that in a lot of places. And we're actually seeing that now in retail outlets, not just the construction industry, but seeing it everywhere as people are coming back. Safe workplaces, what are we doing? And Dr. Clare had a great presentation. It was wonderful to see the controls and the safe workplaces are happening. And those same safe workplaces will be the same. They'll be slightly different. There'll be slightly different equipment, clear screens. It might be blocks of wood. It might be benches. It might be single seats. But basically, the smallest guidelines or the detail to the guidelines will be exactly the same. 1 metre plus, risk assessments for working, and making sure that people are applying the social distancing guidelines. Claire talked about safe equipment and those parts of it as well. Safe equipment, there's going to be tasks now that we can't use and that we're going to have to redo in terms of that. We're going to have to look at how we do the manual handling, how we assist in offloading, unloading pallets, lifting, slinging together, brickwork, electrical work, all that stuff in construction. We've had to more or less rewrite the book in terms of how we're going to plan this with the social distancing guidelines. Risk assessments, Claire talked about it as well, it's no difference. Every one of my risk assessments, we review risk assessments every 6 months anyway, or if something changes, and all risk assessments are sort of being rewritten or having an addendum put to them as well to make sure that we're all looking at the different parts. And again, this is the great thing about the health and safety part of the world for me, is it's a constant change. It's an absolute challenge, and to try and bring in lots of different initiatives and look at things differently in terms of looking at the risk assessment and how we can do that differently and how we can do it within the guidelines is very, very challenging. Safe systems as well, and as Claire talked about earlier on, the legal obligations that we need to do and making sure that whatever country we're in, we're making sure we abide by those regulations. So, building back better, how is that going to happen? Well, we're going to make sure that we need to look at everything here. We need to make sure that the governance and leadership is there. We need to make sure that it's all systems and processes are all there. We need to make sure the people and culture are all there. And all that is going to give us that assurance. So we've got the leadership, we've got the systems and processes, and we've got the people all doing what we say we're going to do, and then we're going to have that insurance there. And it's provided organisations with an opportunity to review everything that they do. And part of this assurance is making sure that the role and contribution that we are making as OSH professionals is absolutely clear. And this, I think, maybe the word opportunity is the wrong word to use, but this is something now that we can then use to ensure that OSH professionals, as they are seen, are absolutely committed and absolutely essential, as Claire was saying earlier on, to make sure that everything that we're doing is correct and following the guidelines as best we can. So, in terms of a case study, I just thought, and I had permission from my leadership team to talk about the sort of things that we're doing. So, in terms of my day job, my real job, I'm a senior HSE manager in England, in London, and I operate one of the largest construction sites that we have in London. And it's 6 buildings, all residential, part residential, some are part retail, all 19 stories, all within the area of a football pitch, more or less. So imagine a massive, massive football pitch, 6 massive buildings in that area. It's the old Metropolitan Police buildings that used to be in London. So in terms of what we did, in terms of the project, we made sure that we started looking at, as exactly as Claire said, the risk assessment. So we had to look at enabling limited works. And this was right at the start of the COVID-19, after the close down. So as soon as we closed down, we were looking at how we were going to come back. And we had to come up with these ideas of how do we get limited works going? So we had to do a massive risk assessment on the site. We had to then ask our subcontractors to do risk assessments. We then had to make sure that we brought in the guidance. And in the UK, it's Build UK and CLC guidance. So we had to follow those. We had to create a document that ensured that not only did we comply, but we ensured that our subcontractors compliant. So we created more or less a complete management system in itself, management arrangements to go out to all our subcontractors to let them know exactly what we're doing. So in terms of your construction phase plan or your health and safety plan as a principal contractor, we gave all that to the subcontractors, and then they then gave everything back, feeding off all the information that we created. And this was the sort of information that we were putting on in terms of consent. We wanted to make sure that everybody completed the consent to work letter, either to us or to their employer. Make sure that they were returning to work under their own volition, that there was nobody forcing them to come back to work, that they were coming back to work under their own way. You're able to leave at work at any time. State that if you're not unwell or live with someone showing symptoms, and just carrying through all those guidelines that we expected people to do. So in terms of the first aid cover, there was a part there where Claire was asked a question and gave a really, really well worded answer. And it's no difference in the UK. The guidelines came out, what we could and what we can't do as first aiders. We've had a couple of small incidents in terms of a cut finger, but nothing that really involved massive first aid. But the guidelines are there in the UK, and we follow those guidelines as well. In terms of our welfare areas, we had to let everyone know in terms of our site rules that we were operating as a welfare area. So we separated the seats, we measured all the tables, we measured the distance within 2 meters, and we're still employing that 2 meters on site, even though it's down to 1 meter now. Perspex screens hanging from the ceiling, white. Nobody was allowed to use microwaves, nobody was allowed to use fridges. Food had to come in, either sort of dry food or sandwiches, nothing that could be heated. And then we slowly changed that as the guidance changed, and when we had everything cleaning, the operatives have to clean up after themselves using wipes, surgical wipes. We have hand sanitizer everywhere, and that's the sort of level that we had to go through. Start finishing times were staggered, and that was a big thing for us. And so we had people coming in at different times in the morning and leaving at different times in the evening. Again, that saved us the problems of people going to eat, the canteen, because we're going from a large canteen area where people can sit together to creating a new canteen where we had the social distancing. The horrible things that you see, and I put that up there for a reason in terms of, it's a big part of when you're on construction sites, it's dusty and people do feel that need to spit, but making sure it was in a tissue and discarded properly in the toilet, not in a bin, and made sure it was done properly. We then had to go from the biometric of fingerprinting, thumbprinting, going to card access, which has worked very well as well. And we had to make sure that our guards were making sure that our security was making sure that everybody was social distancing. And again, making sure, as Claire said earlier on, that the guidelines and making sure that you adhere to your personal hygiene. We tried to stop everyone from exiting the project, and if they had to exit the project, if they had to go somewhere, then they removed their PPE, not to go wandering around, because people will still be anxious, especially people that are not in construction, outside walking the street, or taking their dog, or going shopping, or going for a walk. Seeing people with the PPE on would cause a little bit of anxiety to them. And again, we had to start. People still weren't getting it, so we had to have a real conversation and try and get the learning done. But if the learning wasn't happening, then we had to maybe send them home for the day and then bring them back the next day. And again, the disrespectful behaviour. Some people tend to be very respectful now, and you see that on trains and people all wearing masks and people respecting each other. But some people still will find the need not to be as respectful as they should, and maybe because they're feeling a bit of anxiety as well. And we continued our normal 5-point PPE. And we still carried on with our normal site rules. Again, I mentioned break times were staggered, and we had certain areas where people could smoke and couldn't smoke as normal. And we had to make sure that when we came into our site entrance, there was one stair up and one stair down. We had to make sure that there was one way in and one way out. Now, that changes if there's a fire emergency. Of course, the gates would be open on both sides of the project and people would just disperse, which is one of the ways that we get people off site when there's a fire. It's dispersal, and then we bring them back 20, 40 minutes later. So to ensure that happened, that's been a constant watch, and we've had to employ security to come in and make sure that that's adhered to, because we want people to make sure there is a one-way system. One of the big ones that caused a lot of anxiety for people was the fact that they weren't allowed to use shops, and we tried to keep everybody on site, and that has slowly moved away as more shops have opened. People want to move off site because there's that anxiety issue of being on site all day, working all day, want to go for a walk and go for this. So we had to slowly bring that out, and we had to start letting people again start using the fridges and start using the microwaves in terms of water boilers, and making sure that if there's a seating plan there, that they adhere to that seating plan. Some of the drawings you see now are some of the drawings that we had to do in terms of the logistics team, and you can see quite clearly the areas where people would come in. Again, cubicles to be blocked to mean social distancing for the urinals, only certain wash points to be used, the down only, exit off site and onto site. And these are some of the actions that we had to do. And we have a thing every day called DABs, which is daily activity briefing. And every day we were reinforcing what it is we needed to do as a site. Again, trying to operate social distancing and ask the operatives to adhere to social distancing was a big problem for us. You can see on this drawing now that the 2 meter spacing between the seats, and you can see these seats here that you can see with the dots either side like a domino, they were 4 seats. So you have 2 sitting in one corner, or 1 sitting in one corner, 1 sitting in the other, and sitting in the outside, sitting in the inside. And we're making sure as much as we could that was adhered to. And you can notice in this drawing as well that the kitchen is closed. It's going to reopen again on Monday. I've just been reviewing the risk assessments today. It will have a deep clean, and then we'll go through that social distancing that's happening in other restaurants and other food outlets throughout the world. You can see that we had to create another canteen, and this canteen's in level 2 in one of our buildings. And we had to make sure again that that canteen adhered to social distancing. It was purpose built to be put in there for social distancing. The welfare space. Now this causes a lot of problems, and it's very tightly controlled. We have to make sure that again there's one way in, and anybody going into the changing room has to go out, down the stairs, back around again and get onto site, and coming back has to do the same thing. So the footfall part has increased a lot. And we started to get a lot of people with some anxiety issues in the changing room because people are cycling in the morning, people are running in the morning, people are walking in the morning, people don't want to use the bus. If they do drive, they drive to a car park and then they walk in the distance it takes. They want to have a shower at the end of the day. And again, this is something we have to really look at, and everyone on site has bought into that. It's been very well controlled. So I'm happy to take questions later on about some of the issues that I had in terms of being the senior health and safety manager on my site, working with a fantastic team to create ideas. But I'll just go on then do some other parts in terms of the profession. And as you can see here now, enhancing the Osha profession and globally recognised competencies, and in 3 parts. We have the technical, we have the core, and we have the behavioural. And this is going to be a really challenging part going forward now with IOSH and getting this new framework, this new competency framework going. And I think it's very interesting. Different people within IOSH will have different views. But for me, when you look at all the different parts that make up the technical, the core, and the behavioural, it's very interesting. And this is why I'm going to be driving a lot of getting a lot of young people involved and trying to get a lot of veterans in the community involved in Osha as a second career, because when it comes to that competency framework and the technical core and behavioural, there's a lot of boxes ticked there, and apologies if I'm putting veterans into a pigeonhole here. Again, the IOSH learning and training solutions, lots of work going on there, and you can see some of the parts that we're going on. We've got the executive education, management education, core skills and professional development. We've got CPD courses. We've got an IOSH level 3 qualification now, which is a great thing. So to be a technical member of IOSH, you can do a level 3 course in IOSH, become a technical member, and there's lots of other work going on behind the scenes. Putting courses into Arabic, doing lots of working safely courses, management education, and of course the executive education, which is key, especially on the 45,001, where top management need to know what's going on and really need to understand what it is as OSH professionals we're doing, and IOSH have really keyed into that. this is quite sad, and this is our No Time to Lose campaign, and we've been doing this for a few years now, and I think I presented on it a couple of years ago, Niels, when you very kindly invited me out. And again, you know, seeing one person die every minute from a work-related cancer, that is pretty sad, and a lot of that is, you know, the sort of Asia part, you know, all that side of the world, and it's causing a lot of angst, and we know that, and IOSH in itself has been really driving this No Time to Lose, and you know, having, you know, 800,000, you know, 750,000 people dying a year from work-related cancer is just not on. And it is just going through it again, and what's it for? And my company has signed up to it, and we're going to be doing a lot more going forward. And it really is, the No Time to Lose campaign is there to raise awareness of significant health issues facing employees. And some of the resources that IOSH provide and working in hand with their branding team is absolutely fantastic. And if you've got some great ideas that you want to bring to the table in terms of occupational cancer, then it's really a good thing to do, and I would ask people to try and get involved if they can. And that's it, you know, a little bit of the IOSH part there and what we do, and a little bit of the practical side, taking some of those amazing points that Claire brought up in her presentation and put that into a practical sense. I'm living it every day. I would say breathing it every day. I travel 130 miles each way, each day from my farm in the countryside, where there's been no cases of COVID and deaths, some cases of illness, and then going to London, where that's been the largest hitting area for COVID cases, and on site with over 550, 600 people every day, you know, 5 days a week. So I'm living it, I'm doing it. Any information that you would like to have, if you need any practical pictures, just send emails and let me know, Herman, and I'll get that on.
Jimmy, thank you so much for your time. That was a wonderful presentation. I do have just a few questions, if you don't mind hanging on for 1 or 2 minutes. But before I get into those questions, I'm going to ask Gareth, can we just start the second poll question?
Yes, Herman, we're launching it now.
Okay, has your organization been able to comply with COVID-19 directions on occupational health and safety measures in certain workplaces? You can go ahead and answer that poll. Jimmy, in your presentation, you referred to using guards to help bring down the cases of transmission. Do you find that this is an effective measure, and how do people look at it on sites, especially in terms of the workers, or should we leave it to the workers to adhere to the social distancing?
That's a great question, Herman. So what we did was, over in the first sort of 4 weeks that it was happening, there was a lot of confusion, and a lot of people that have been working on the site for a long time coming back, and the site is more or less changed for them, because the way that they would normally come in, go to work, the way it was trying to educate them. So it was more of a presence to say, oh, you're going the wrong way, you need to go that way. And after a few weeks, those behaviours changed, and so that presence came down. So it wasn't so much of, you know, really the discipline part of guards. It was more just to say, hi, I'm here. The sign says there, and it was just that education part. So it went very, very well. A lot of people took it on board, and having those guards to just be outside, just to control people walking in and out, and just re-educating, which is what they did. It was fantastic.
Oh, that's fantastic. And then you made reference to smoking areas. So I'm not sure if you're aware that there's a complete ban on cigarettes in South Africa. I just wanted to know from the UK, is there a ban, number one, and number two, what is your view on that?
No, there's no ban to smoking, and we have smoking areas in just one specific area where people can go and smoke, and we have a vaping area which is away off the sort of occupational part of the site, so way to the back where nobody can see. You know, what do you do? There's two issues here on a construction site. If you've got a construction site with 600 people and you're building 6 buildings with 4 basements and 19 levels, you're actually going to drive it underground. And what do? Do you send people off site where they're smoking off-site and collating and not in that social distancing area. So on the site, we can control it. We can control it by social distancing. We can ensure that our black hats and our supervisors make sure that that's done. So it's whatever way you look at it from a risk assessment basis, Herman.
Perfect. And just one more. With the UK going into the cold season later this year, are you all preparing for a spike in cases?
Yeah, well, I mean, they're talking about having that second spike, and our Prime Minister's talking about that regularly. So I think the best thing for us to do and what we talk about on our sites is to make sure that we keep social distancing, keep washing the hands, keep and making sure that if you're not on site that you're social distancing as well, and really trying to get that message across that it hasn't gone away, it's just sleeping at the moment, and it is going to come back. And when it comes back, I think we're going to be in a better position. But we'll continue to risk assess on our site. We'll continue to have dialogue. We'll continue to do everything we do. And isn't it fantastic doing remote meetings? Love it. Absolutely brilliant. So thank you so much, Herman. Great questions.
Thanks, Jeremy. Thank you so much for your time. Gareth, do we have the results of that poll?
Yes, sharing now for you, Herman.
Okay, so the question was, has your organization been able to comply with COVID-19 directions on occupational health and safety measures in certain workplaces? And we had a resounding 94% saying yes, with only 7% saying no. Thanks, Gareth. Okay, moving on then. We have Sean Chester patiently waiting. So Sean is the technical director at Apex Environmental. Sean will be talking to us on COVID-19 risk assessment and barrier management. So just a little bit about Sean. He has a master's degree in occupational hygiene through WITS. He's a registered occupational hygienist, honorary lecturer at the Discipline of Occupational and Environmental Health in UKZN, technical director at Apex Environmental. In the COVID-19 pandemic response movement, Sean serves as an advisor on both the national and provincial occupational health task teams. Sean has limitless curiosity for anything to do with toxicology, microbiology, and physiology, and his lifelong passion for teaching is demonstrated in the many lectures and conferences he has spoken at and committees he has served on. So Sean, a very big welcome to you. Thank you for giving us your time today. I'm going to switch off now and hand over to you.
Yeah, nice to be here. Thank you very much to FEM and Herman for that introduction, and obviously to Sayosh and the guys for hosting. Let's get on with it. Gareth, everything good there?
Yes, thanks, Sean. Full screen, everything awesome. Thank you. Enjoy.
Okay. Folks, yeah, I mean, there's been a hell of a lot of discussion around risk assessments and the different barriers and everything like that this morning. I think both Claire and James did a great job. I'm sure Quibus is also going to be mentioning quite a lot of stuff as well in his presentation after mine. So how much can I add? So I've got a little bit more of a sort of shoot from the hip style. I'm very keen on policies and procedures, and I absolutely agree with everything is a foundation, is in the written word, and then that actually gets branched out from there. But I certainly would not want to repeat a lot of the stuff that's being mentioned already, and luckily my presentation doesn't do that. So I will just commence with the way that I'm going to do it. So let's just always start with where we are. So this is the Johns Hopkins University. They publish this sort of every day, and you get an update. This is the incidence reports, and you can see this. Our last update is yesterday at 5:35 p.m. Eastern time. I just want to quickly switch that phone off. Sorry. And so incidence is always good because, you know, we lose track of the numbers, and we lose track of how much the stuff is actually growing every day on a daily basis. And, you know, it kind of gets overwhelming. So what I do is I just check in every couple of weeks, every couple of days, and I have a look. So, okay, yes, the disease is still there. We need to actually keep on managing it. And then I obviously go through to all of the various there's a few really key areas that I follow, like the Worldometer. And then I just always make sure that I'm kept up to date with where these numbers are, because as this disease spreads, the pandemic will not go away, and neither will the lockdowns, and neither will all the the issues around that as well. So I think it's just really important that you check into these sorts of things. So this is just one of the examples of where you can go to see what the incidence is as well. And this is where we are in terms of our new cases. And you can see South Africa is scrummaging around there in number 5, that little point up there. So we're still quite low. We're still in amongst the sector of relatively low case numbers relative to sort of the big guys out there. So we are managing, and it's yes, we are growing very, very quickly, but it is something that we have to just keep an eye on as well. And it's very good to have a look at graphs and that to check into that too. This is the worldometer, and there's some really good figures in that you can log into, but the scale that they're using over here is the logarithmic scale. And I find the logarithmic scale to be the most useful indicator of growth, because it doesn't just give you like this just shooting parameter that just goes off into the sky. What it does, it actually gives you just a linear line, and you can actually see that it's just an ever increasing line. And what this tells you, this actually takes it down to the 10th decimal, the log scale of it. And as long as this line is actually on an upward curve, it's just up from flat, you know that our numbers are increasing all the time. And I think this is a very good thing to check in, because when you see the other scale, when you see the linear scale, it just basically looks like a skyrocket. But that does get to a point where it will actually, it won't be able to breach that. It'll get to a certain point, and then it'll stay there, and it will start sort of knocking against that. So logarithmic scale doesn't do that. It's not as sensitive to sort of daily or weekly cases. And so it's a much better indicator for you to look into. So as you can see, our deaths at the moment, we're sitting at about 7,000 deaths, 452,000 cases as of yesterday, and 274,000 have recovered. So it's still quite interesting to see how this disease is progressing, in that we don't have a very high fatality rate relative to our cases, and that is unusual globally. So it's interesting, and I think the science and epidemiologists and that will actually unpack it as we go along. But very, very important for us to be able to track these. And if we, as safety and health professionals, as an occupational hygienist, I feel like it's my responsibility to be able to track this and be able to report on these figures to anybody that asks on a regular basis. So I certainly put that gauntlet down to the audience here as well. Then if we look at the mortality rate, South Africa, we're number 5 in the case rate, but we're quite far down. I think we're 11 or so on the mortality rate. But you can see, like the United Kingdom and Peru and Chile, they are very, very high in terms of their mortality, and they are relating it predominantly to, again, the science is all under constant review and it's highly dynamic, but they are relating these cases directly to old age or an aged population, where South Africa is considered to have a relatively young population. So, and yeah, again, this is, as I say, it's a moving target all the time, and these things are going to change, or at least the explanation of them are going to change, and we need to just be aware of that. And it's a good figure to keep on. So, what do we really understand about coronavirus? We understand that it's both transmitted from person to person, so it's a human disease. It's transmitted from person via fomite, i.e. object. It's transmitted by coughing and sneezing as well. So, and then there's a social distance that we've actually got now. We've pegged onto the 1.5 meters. A lot of people are starting to go into the 2 meters as a minimum distance for safety. And then there's also this airborne potential, where there's this nuclear. So what have we got now? If we had to lock down planet Earth for 2 weeks and isolate every single person from now, let's even make it 3 weeks, you would end up with 0 COVID. It would just stop. Why? Because you are isolating person. The person's infected or healthy. That infected person cannot spread the disease at all. But now we all, human beings, we all got to work, we all got to go and actually life, and so we can't really do that. So there's these rules, and we've spoken about them already in terms of barriers and all that, and we'll talk about that a little bit further. I also just want to just mention that toilets, the World Health Organization now has already declared toilets and the flushing of toilets to be a source of airborne transmission. So we have to try and isolate. That's our number one solution to preventing this. And as I say, it's not. We all understand that it's actually not possible. And so, I mean, then we have to start looking at the type of things that we can do to intervene. So let's just say, for example, with a toilet, an easy thing you can do is actually just close the lid, and that would certainly stop a lot of transmission. And I've done some very good anecdotal research on this stuff, and it certainly does work. And we've done some testing on that in the past, and that's a very, very good strategy. And then, obviously, the next thing we have to do, we've got to interrupt the transmission pathway, because now it's either going to be airborne, going through to the healthy person, and we want to keep that healthy person healthy. We do not want that person to be getting a COVID positive test, and that's you and me, because I believe I'm still healthy. There might be a few among you that are in the audience now that are asymptomatic or symptomatic, and if you're symptomatic, wish you well, that's for sure. So we've got to look at the design of our buildings and actually how we protect people. So let's actually look at some of the barriers that we would stop to use as a barrier between this person being infected, or symptomatic or asymptomatic, infecting that the healthy person and getting that healthy person to have a positive case. And that's a terrifying and life-changing event, not only because of the disease at the moment. Certainly in South Africa, we have very strict protocols around the way we treat positive cases. They've got to be isolated, they've got to be off work. If they exhaust their leave pay, they would not then qualify for any pay. If it's occupationally, if it's not, it has to be proven to be an occupationally related one, and we'll go into that a little bit further on. But we can isolate by distance, and we can provide a mask. Obviously, we can sanitize, disinfect, and we've got to ventilate. These are some of the barriers that we're going to be able to stop those particles, whether it's actually the aerosolized nuclei or actually the larger droplets, getting into that space. One of the key areas, and we can speak about that a little bit further on as well, is around the HVAC system. So this over here is an example, and I hope you can all see that, of a central air conditioning system. So you get central air conditioning systems that just provide recirculated air, just like your normal wall-mounted split unit air conditioner. Then you get other ones that actually have a ventilation system in it, which in that they actually introduce fresh air into the environment. So you need to have a look at that. What you do is you'd get your building manager or your facility manager to go, and you'd actually have a look at the air handling unit itself. And then inside that, you'll actually see an air intake port. It's a very simple thing. It just looks like a little louver box, and it's on the handling system. Sorry, that's my 11-year-old son doing his schoolwork and sneezing at the same time. So what you would find is that this air intake could either be set at between 5 and 15%. It gets a little bit difficult to make it up above 15%, which would be ideal. During winter, we can put it up to 100% because the outside air is actually cool enough. Or in Joburg or Cape Town, certainly, you would find that the air is even cooler than what the inside air is. So you wouldn't have to put your cooling system on. Your cooling coils on. And so what you'd have 100% fresh air going in, and that would be circulated around the building, and then fresh air would be supplied. However, if you didn't have this air intake, or if the air intake, the fresh air component was so small in comparison to the occupancy levels within this, that it would not be enough to dilute or disperse the virus. And then you'd start finding that your incidence of COVID would increase inside the environment. So we're just going to put that aside for a second, and let's just quickly cover this, and not in great detail, but it's a very, very large misconception and a very widely held misconception that a split unit air conditioner provides any fresh air at all. They don't. If you get your old window shaker, it's just like if you look in your vehicle and you'll see on the vehicle there'll be a little fan sitting that says it's got a little fresh air sitting on there. Some of the older split unit air conditioners do have that, but by and large, 99.9 recurring of these are just pure recirculation. It just takes the warm air, recirculates it over the cooling coils, and then pushes it back again. So that's a very important thing. So now, what have we got? So our options are, we've actually controlled the airspace. You can control it very easily within a bathroom or within a workspace. If you don't have any fresh air introduced, you can open up your windows, or you can actually put something like a force extraction fan. And these little fans can do a hell of a lot, and they're pretty inexpensive to install in an environment. There's also very, very low cost and dynamic systems that you can actually attach flexi ducting to, and you could evacuate an area like that if you want to, even if the area doesn't have a window or doesn't have access to a window that's close by. So the next thing we do, obviously, is our hands are potentially big sources. So isolate the hands. What do we do those? We clean them. We use sanitizer and sorry. And then also any kind of droplet infection that ends up on your work surfaces, you've got to disinfect, regularly disinfect. So when you've got electronic equipment, we must just make sure that you're using maybe an alcohol-based sanitizer. More than 70% is the spec, because then it doesn't get right down into the equipment and destroy it, like if you're using a water-based thing, like sodium hydroxide or jet. But ultimately, what we really want to do, we've got to make sure that the direct contact, the indirect contact, all the droplets do not make it to a healthy worker, a healthy person. So that is the critical. So I mean, really, how do we do that? It's a pretty complicated space, but at the same time, there's a lot of lateral thinking that goes into this. And so the workspaces are so dynamic. I mean, Claire was saying early on, and giving some of the ideas that she was presenting, and really there's so many ideas, and I don't want to unpack those, although I had some of them prepared in terms of the discussion. So I was just thinking, I was musing, and I was wondering, you know, what was a disaster construction site? I mean, if you're looking back in history and you look at the Great Pyramid, I mean, they were obviously really well run. I know there's whips and chains involved. But one way there was a common objective for everybody, and that was obviously in the Tower of Babel.
Hi, Sean. Apologies to interrupt.
Yeah, sure.
Making your presentation full screen again for us.
I sure will do.
Thank you, sir.
So the Tower of Babel was interesting. It just sort of surfaced into my mind, and I was really quite intrigued what it must have been like to work in that place, because they all had this common objective. I mean, every construction goal that you have, this is the Deloitte building on the left-hand side over there. Every construction has an objective. I mean, you want to get the thing finished. It starts off as an idea, and I love the idea that construction's like that, because it's building something new. It's never been, and it's conceptualized, and it's ideated, and then it's planned. And then eventually start breaking ground on this. So Babel fell apart, according to the scriptures, because of a lack of communication through a lack of language. Now, our work sites in South Africa are way more complex than what you'd find in homogenous work sites, homogenous culture, homogenous language work sites that are found overseas. In South Africa, we've got sort of so many different languages, so many different cultures, such interesting and diverse perspectives about what something is. And so, although the plan to make this thing, this idea into a physical built environment that is actually occupied, is very, very different in terms of the way we see things. And if we don't actually have cohesion in communication right from the ground, all the way up to the final product, there's just going to be difficulty all the way along those things. You've got the moving parts in a construction site are just crazy anyway. And I find it intriguing that you've got the lowest level educated to the highest level educated people all involved in the same project. And you know, the diversity is just crazy. So I really respect the idea that to be able to communicate clearly from that planning and policy phase, as Claire says, all the way through to communicate that from the ground up. You've got to not just issue instruction. Garth was speaking last week about behavioral safety, and it's such an important issue, because if you don't have clear and distinctive communication of your intention, of your spirit, of what your objective is, and actually buy-in all the way through, that just creates more and more kind of chaos. So, and I think I liked Claire's comment early on, is that a lot of the sites that she's visiting now are actually, their housekeeping is a lot better. Everybody's kind of more geared to working together. Now, if we put the same kind of amplification into the other issues in construction, or other issues in health and safety, you'd actually probably find that there'd be a lot less, as James is saying, is the cancers and the ergonomic risks, or even the fatalities in that, you know, because as soon as we amplify something, you actually get behavioral change. And when you get behavioral change, you actually get something that's actually more long-lasting and permanent, and probably a lot more precious, because then you actually get societal change. And I really believe that there's this COVID platform is actually something that we can use. We can use it as a communication tool to actually build bridges to all the other parts of our work as health and safety professionals. So a very interesting idea to me, and I just wanted to tease it out, and I thought it was a nice thing to go. But what did Babel need, and what do we need in COVID to be able to get through this pandemic in a way that actually keeps, firstly, our people safe and healthy, and secondly, our economy intact? We know that the economic impact of having a COVID positive person on site is potentially really, really large if that site hasn't been properly demarcated and devised and divisioned. And there's also this responsibility to go off-site as well. What do your workers do when they go home? How do they get to work? Where do they shop? And we'll have a look at that a little bit further on. So this is an example of where barriers failed completely. I mean, in this example, it's physical barriers. What they did in in South Korea and Seoul, there were 206 call center operatives, and 94% of them actually got COVID. Interestingly enough, so what they found, the critical issue in this was not only social distance, because there were other areas where there was social distancing. There's similar social distancing. So if you look over here, what they found over here is the ventilation system as well was not very good. So ventilation is a key barrier, is very, very much proven by this, where you actually had social distancing over there. But the question I'm asking with this is that, okay, so let me maybe just go back on this a bit, is that these people were all going out for lunches and communicating in other areas, in common areas. However, they found that the greatest causative agent in this was the fact that they all work together inside this one environment. So it raises questions. Sometimes maybe it raises more questions than it provides answers, but it's definitely worth unpacking. So what constitutes a barrier? Well, barriers are everything. Barriers are your thoughts. So barriers are physical, barriers are emotional, barriers are psychological, barriers are policy. So there's all these multi-level, multifaceted thing, and that's why I will keep on referring to this idea of EQ is the biggest issue within this pandemic. Because if I go down to the local shop and I see somebody not wearing a mask, I'm feeling unprotected. But what gives that person? There's so much information out here. What makes people not want to wear a mask? Because they're uncomfortable, or is it a belief system that it's not a problem? Is that belief system actually relevant to where we are, or is it more to do with a scientific background of where they're coming from. Is it provable or unprovable? But my real issue is that if you take every single thing away from what you've heard in terms of the whole projection, the 180-degree tangent on what COVID is, and you narrow it down to what the consequences are on side of having a COVID positive case, then that actually absolutely supports the idea of actually having barriers, because it can close down a work section, it can close down a work site, and it can affect the economy and the whole project. And depending whether you're in manufacturing, construction, it's so bad. So do barriers keep office hours? Well, I think from what we're speaking, they obviously don't. So, you know, there's been so many examples that have been brought up today that are just brilliant. And I think we're just going to unpack what I just went through off the top of my head, and I just went, okay, what's this, what's that, what's that? This is barrier management. It actually should be barrier management. Freudian slip there. Okay, so your pinch point. So what is a pinch point? It's a congregation of people that come together. It could be all starting work at the same time, all going on lunch at the same time, all communicating in a way that, in physical distance. It could be driving to work in a taxi. That's a pinch point. So it's these high congregation points. You've got to be able to assess those. And each one of those assessments would always be a high risk to the ability for your operation to stay open if they are not properly controlled. And we'll talk about that a little bit later on. So social distancing, we've spoken to you about it. We've spoken about social barriers. We've spoken about disinfection. Just a very quick one on disinfection. Just remember the 70% alcohol, as well as any of the other chemicals that they have. The EPA has got a whole list. The CDC's got a whole list. There's a lot of information around on chemicals. Make sure your dilution rate is good, and make sure you use your contact time. So your dose and your contact time are two very important things. And make sure that you always clean before you disinfect. Claire again was talking about fumigation of dirty cars. So if that car's dirty and you're fumigating and you're putting a fogger inside that, what ability has that mist got to actually penetrate through that dirt and actually get to where the virus is? What you want to do is you want to wipe everything nice and clean, and then you want to disinfect. So air quality and ventilation, we're going to speak about that a little bit more just now. Toilet usage and flushage, we've spoken about. EQ is going to be, it's just a common theme in the back of this, and I'll ask you, colleagues and friends, is that as you go through this with me, understand that what we are trying to achieve on this talk in this day, with everybody and every other day with our kids and everything like that, is to actually help people, to enable them to understand why we're doing the things that we're doing. It's not just this is the rules, because the rules will always get broken, and we've seen that in construction over the last 100 years and further. So EQ is incredibly important. So we want our people to arrive with good practice, and we want them to stay with good practice. The transportation system is a nightmare, and we want to unpack that a little bit quickly a little bit later on. We want the medical screening. The policies and the SOPs are absolutely imperative. I'm not going to unpack them now. De-densification, James spoke about that, keeping people at home. Obviously, we do that a lot, but also then arriving at different times as well. Your temporary isolation of your person under investigation. Waste disposal is another thing that actually seems to be neglected on the sites that we're going to. You're finding that the waste disposal sites are being handled in a very haphazard way. Vulnerable workers, we spoke about that earlier, and we'll cover it very briefly later on. Information and training, incredibly important in this, but remember, information and training, not just ticking the box that we've done it, so we can actually sign our risk assessment off on this, because getting it wrong and having people not changing their behavior is highly consequential for our workplaces because of the rules around the OHS direction. Workplace discipline, we know we've got section 37 in the Act that says that you can act in connivance. If you tell somebody that they must wear their mask or they must stay further apart, and your supervisor repeats that, and eventually people, well, he just gives up because they're not listening. And he goes, oh, well, that's not my problem. Then he's actually acting in connivance, and that will be shown in a court. Personal protective equipment. I'm going to do a little demonstration just now. Is it the correct type? Is it the proper use? Not all PPE is created equal, and we know that from Rajan's talk Professor Rajan Naidu's talk last week. If you attended that, you'll recognize that that we don't regard a cloth mask like this as a piece of PPE. It is not. It's actually an isolation device. It actually protects the person, not the wearer, but the person that has been interacted with, the community. And do we maintain these things, or do we clean them or whatever? So let's have a look at your risk amplification points. I think it's an important point. So if you look at this workplace over here, this is obviously before COVID. This is just a photo downloaded once off Google Images for me, but this sort of environment would not work. You'd have to put sort of social distancing in between that, and you'd have to have work structures that were there. I actually found a document in the UK where you would, if you want the people to work within 2 meters of each other, you'd actually have to put apply for a permit to work within 2 meters of somebody. And then that would actually require a special risk assessment, just like you do your permit for work for hot work in volatile areas and that sort of stuff. So we've spoken about these risk amplification points, and if you can organize your work in a way that there is the social distancing and there's the masks and all that sort of thing, then you really have to focus your next area is to focus on your risk amplification points. And very important, I'm going to go back to over here, this mask use compliance. And that is very, very difficult for you to check because wearing a mask is wearing a mask. And we'll talk about that just now. So if you might look like you're wearing a mask, but you actually aren't. Then your poorly ventilated areas are a big issue. And then, reinforcement through repetition, again, through these presentations that preceded this one, your change rooms and your toilets, very, very big risk amplification points as well, because that's where people drop their guard and where you can't sit and monitor them, because what's going on inside a change room, it's very difficult to see. So it's very important, and I'm sure what you've got from this presentation and previous ones is that you've got a very dynamic environment, and that environment certainly needs to be assessed independently and individually. You can't take a generic thing like a group. If you're a group operation, and you can't take one set of rules and actually just cover all your sites, even if there's 30 of them at a time. You'd have to have that on the ground risk assessment. You'd have to have on that ground education. You'd have to have on that ground EQ to make sure that you are protecting your company and your employees. So this is a dynamic process as well. A lot of people go, well, I've done my risk assessment. I mean, we even know with the releases of the various directions, the 2 of them, the releases from the NCID as well as the Department of Health, and that things are changing all the time. The way that, I mean, the aerosolization of the disease at the moment is the latest big World Health Organization declaration, and there will be more. There'll be virulence, the organism being more virulent through certain mechanisms, or more affects some people in certain ways. A big one that's happening in South Africa at the moment is this lack of taste and smell that doctors are reporting of their patients. So it's a very, very dynamic process, and you have to be able to check in all the time to observe it. Garth Hunter spoke to you guys last, the audience, some of the audience here last week, and he spoke about this position paper. It's a brilliant paper. So if you really would like it, please feel free to email me, and I'll get you the official copy. It's good. But one of the things that him and Dr. Q worked on, and I think to me it's a game changer, because office ventilation is very, very difficult to really assess, because What you can do is you can take the floor area and then you can take the number of people and you can take the amount of fresh air that's being provided. Then you can actually start doing all sorts of calculations like volumetric calculations per person, how many liters per person per second, how many air changes per hour, and all that. So we're going like 6 or 7 liters per person per second, or 6 air changes per hour, and that becomes very technical. But what you can do is that, and I've actually found this as my experience, and I've done a few presentations on the use of carbon dioxide as an indicator gas at conferences and stuff, and it really is a very, very cool way of doing something pretty inexpensively, and that is to actually take a carbon dioxide meter. It's an infrared meter, so it doesn't require calibration. It's not electrochemical, so the sensor doesn't get eaten up or anything like that. And you can have this little portable system, and you can walk through a building in that space, and you can check the carbon dioxide concentrations on a dynamic basis. So you look at your high occupancy areas your areas in high occupancy periods. You can monitor those CO2 concentrations. You can say, whoa, okay, I'm picking up say 500 ppm in here. Then you go outside and you see it's 280. Oh no, so my outside area is 280. I'm picking 400. I'm picking up 400 inside the building. So then I'm at 680. So I'm way within compliance levels. So that was my son speaking out loud over there. Manchester. Anyway, so this is a very cool instrument to use. So basically, what you'll do is you'll just go outside, you'll measure your concentration, you'll go inside and you'll measure your concentration. Your inside concentration must not exceed outside plus 400. So in general, in well-ventilated areas, and believe me, I've done hundreds and hundreds and hundreds of buildings like this, in well-ventilated buildings, you are always below around the 800 mark. In poorly ventilated buildings, you're always above the 800 mark. Sometimes the highest that we've got is, ironically, doing a Department of Labour presentation to all the inspectors in Durban, and we've got 2,500 parts per million inside that training room. So in a poorly ventilated area, very little diffusion or dilution of the virus, way higher ability for the virus to communicate across people. So very, very cool and interesting tool. Right, do masks actually work? So this is a study that was done to check on whether these virus droplets actually work. So people wearing masks and people not wearing masks. So what they did, they checked the positive cases through a nasal swab and the throat swab, and there were lots of positive cases. And they alliterated that down to about 230 people. And they got 230 people involved in the study. And what they did is that they just put them inside a room, and they put like a petri dish, a virus catching device, and they allowed them to speak and to cough and everything like that for a 30-minute period, firstly with a mask and secondly without a mask. So if a person was speaking for, just basically, if the person was speaking and didn't have a mask on, what you found is that there was definitely a serious result, a result that was there that actually proved that the masks actually work. And secondly, if the person had a mask on, you can see this black line indicates the average. The average was 0 if the person had a mask on. So what I'm going to do now, I'm going to share my screen. Am I full screen on this yet? Gareth?
No, Sean, not at the moment. If you can try that again for us.
All right, so I need to maybe stop share. How's that?
You've stopped shared now.
So can you see me? Am I full screen?
Yes, yeah, you're full screen.
Okay, guys, so what we're going to do is we're going to do a little experiment. This is an anecdotal experiment, but it adds a little bit of a depth. It's a rule of thumb. It involves a candle. And what I'm going to do is I'm going to try the various masks that are out there. Now, if you saw somebody walking around with this bad boy over here, what would you think? Yo, that guy's definitely protected. And you'd be right. But this is a P3 respirator. It's also got organic, and it's called an APEK, but it's got a P3 filter. So this will not allow the viruses through. It's got a 99% filtration efficiency. But you'll see whether it works or not. If somebody's wearing this, you're going to go, oh, I feel comfortable around this guy. I'm not going to put the... If I can blow this candle out, that means that this mask is ineffective in protecting you from me. So why is that? Why did this fail? And this is a very important question. And I want to ask the same question when you go around and you see masks like this. Can you see there's something in common with these two masks? That's this valve. The valve, although when I breathe in, when I inhale, the air is actually being filtered. But when I exhale, it's actually coming out of this valve over here, and it's unfiltered air. So when you see on Facebook and that everybody's advertising and you see these masks around, but now they're becoming very popular with a little filter in the side of them. Those masks do not work. They do not protect. They may protect the wearer to an extent, but they do not protect the person that they interact with. So if they're out in the shopping malls, or if they're on a site or in a construction site or whatever, do not use a mask. Do not allow a mask with a valve onto your site. That is not working. All right, so we've cleared that up. But what should we use? So the spec is actually an FFP2 or an N95. This is what the medical personnel or the medical fraternity use. This is a Draeger mask. It's an FFP2. If you look on the sides over here, it'll have Draeger and it's got FFP2 and all the ISO accreditation. So this is a validated mask. And this is what I used to go shopping actually, because it actually protects me as the wearer, but it will also protect you when I interact with you as well. So will this pass the candle blowing test? Absolutely. FFP2, this is the reason why it's actually spec'd like this. So it's a very, very good mask. It's an unvalved mask and it works well. Now there are cloth masks and there are cloth masks. I unfortunately don't have an example of a bad cloth mask, but we'll go through using just a bandana. This is the Apex spec mask that we've researched and we found it to be the best. It's got a little toggle at the back. Is this mask protecting you? Yes, it is. But now, what about these thinner masks, these sort of 1-ply, 2-ply masks? Because you know you can use anything. You can put a t-shirt, you can put a pair of underpants or anything like that that you want. So let's just say this is how we see a lot of people. I mean, Garth said, I think it's in Germany where they found that if you're running with somebody, you should be at least about 20 meters away from them. If you remember that from last week. I think the skulls are pretty descriptive as to what the problem is there, as to what's going to happen. So it's an interesting little anecdotal test that you can use, and I find it to be very useful. Right, folks, just go back onto the mask. The mask does work. It should be validated. If you can't get hold of validated ones, make sure that your mask is a 3-ply mask. So it'll have 3 layers on it. And try the candle test. I mean, you can't do the candle test on your workers, but it's something that you could get a little bit more familiar with what's going on. and understand that obviously the less the barrier, the more the ability for aerosols and that to go through. This is a study that was done between 3 countries, so the Czech Republic, Portugal, and Sweden. So if you know anything about, if you've been following the pandemic, you'll understand that Sweden is being fairly heavily criticized, and now some research is coming out to say that they were on the right track all along, is that they kind of relaxed all their provisions. So they didn't really go into lockdown. What they did was they isolated the elder people, they isolated their vulnerable people. They also they restricted gatherings and all that sort of thing, and they put out guidelines, but there wasn't very strict control. Portugal kind of had an intermediate sort of thing, and then the Czechoslovakia was very strict. They had a big masks for all campaign. People were knitting them inside their houses and everything like that. They also they had lots of lockdown, lots of restriction. They had a lot of behavior and all that sort of thing. They were very similar to what our rules are, and you can actually see the difference. These researchers took these countries, and you can see they got around about the same population. They're kind of the same sort of hemisphere of culture here and there, and so there were some similarities between them. They were fairly homogeneous as populations. So what happened in that is, if you look at Chechnya, the total cases were completely different. If you look over here, Sweden had 14,000 cases, Portugal had 20,000 cases, but you can see over here there's 7,000 cases just under. But if you look at the serious or critical numbers, and this is the parameter that I'm always most interested in, and as with these researchers, if you look at that, you can see that Sweden had 521 serious cases, and the lowest one being Chechnya was 75. So just basically proving that the barriers do work when they are up. So the higher the contact, there's consequences, there's economic consequences, there's social consequences, there's frustrations, but the barriers do absolutely work. Guys, I'm not going to go through this at all. This is the OHS direction. And really, I just want to emphasize a few things. Again, if you want this direction, I'll email it to you. Just please email me, sean@apexenvironment.co.za. And what I can do is I'll send you a risk workbook that's actually got a yes, no, and a little comments column in it. And I'll actually send you a summary table of the direction and the various categories of things, as well as the direction if you want that too. So just email me. So what I'd like to just maybe emphasize is a few of these things is, like, if we look at the symptom screening for COVID positive cases, so we have to assess the transmission risk in the workplace and disinfect the area. So the direction says that if you get a COVID positive case, you've got to assess the transmission risk. And that's what this talk is about, is actually about the risk assessment. And we're going to go into sort of an easy way to challenge test it a little bit later. Then again, if you've got a low risk exposure, so basically if you assess the risk, you've got somebody in your workplace that is now tested COVID positive, and you look at all your contact tracing and you go, oh, hold on again, all those contacts are low risk. That person is actually allowed to continue working if they're a contact, because they're low risk, not whether they've got the disease or not. We're not screening them. We're just looking at the risk assessment of it. And it's an incredibly important thing for the continuation of work continuity, to understand that. If you look at sanitizers as well, weirdly, you've got to provide the workers of sufficient supplies of hand sanitizer and at the workstation, and for both the worker and the person with whom the worker has interaction. So if your worker interacts with the public, you need to make sure that they are providing hand sanitizer. And an easy example is if you go down to your local shopping mall and you're getting sanitized, you're a member of the public, their workers actually being protected and complying with this direction by the fact that you're being hand sanitized when you go in. So then also you need to instruct the employees to interact with the public to sanitize their hands between and each interaction. So if anybody, and again, if you're looking at your shopping mall, that is being complied with, but is it being complied with within construction sites or when the people are kind of on their way in and out of their workplace. Cloth masks as well. I know that it sounds like Claire and the team have been working on sectoral guidelines. I'm not sure how far that's actually got. I didn't really catch how far that got in. But the number and replaceability of those cloth masks, you remember, a mask is not something you just issue, and it's one of my biggest bugbears that I have with things like cloth masks, is that you think you're giving the person to and that's your job done. But there's a hell of a lot of maintenance that actually has to go. It's a non-disposable, it's a reusable device. This. And what happens is it actually becomes a microclimate. If you're breathing into it all the time, that microclimate is actually a perfect medium for all sorts of things to grow. Bacteria, viruses, fungi, all sorts of things can exist inside that. And this can become a fomite in its own right. So the instruction on how to maintain it, how to care for it, how to sterilize it, how to clean it, all that sort of thing are vitally important when using cloth masks. So your risk assessment may also recommend other types of personal protective equipment. So if you've been exposed to dust, we've come across sites now where the guys would normally be exposed to dust, and what they'd be doing is being exposed to silica. So they should be using an FFP2 like this. However, because cloth masks are reusable and it's what everybody's gotten into, they're quite comfortable wearing them. They take this off and they let them wear this during the work. If the PPE on your risk assessment is for, say, silica or welding fumes or whatever, you use a device that is actually spec'd for the occupational risk rather than the COVID risk. And that will always be, because it's validated, it will always be higher than what a cloth mask is providing anyway. And if you are working with the public, construction sites are very dynamic from very small to very big. You must make sure that there's a 1.5 meter distance between the workers and the members of the public at all times. And the ventilation, keep the workplace well ventilated by natural or mechanical means, and I think we've spoken about that. Your worker screening, I've seen a lot of sites where the guys are not using electronic systems. At Apex Environmental, we use Mabenzi, and Mabenzi is basically a medical passport, and it's developed in conjunction with the University of Cape Town and University of KwaZulu-Natal. And basically, you register your company, and anybody that comes in there can just actually use the site. It's got an app that you just log into, and you go through all the standard NCID screening answers, and that actually gets kept as a record. The problem with using pen and paper and that is that obviously there's a lot of potential handling. So that's what I would call an amplification point or a risk amplification point. And so if you can go digital with that, I know it's unlikely for all your sites to be like that, but wherever you can, you should certainly try and use that. I know with the UKZN, what they do is that before they even come to work, the morning before, or even late at night, the night before, they can fill it in and they can just show that passport to security in the morning. So conducting the risk assessment, I'm not going to, again, go into too much depth over here. I'm going to cover maybe some of the stuff that was covered earlier, but let's just go with it. So your risk assessment tools, you can get incredibly complicated with these things. You can start looking at all sorts of parameters, whether the place is ventilated or where there's distance, what's the contact period, and all that sort of thing. And you come up with this very convoluted kind of thing. Expert level risk assessment is not for everybody. It's something at Apex that we've actually also taken more of a dumbed down or simpler or pragmatic approach, and we wouldn't use something like this. So when you see this, that this is not the expectation from the Department of Employment and Labour, you can use a very basic assessment. This is the tool that the Department of Employment and Labour have put out there. I had something to do with drawing it up, so I quite like it. But the ultimate thing is that you can actually, you can put your source of hazard, your routes of exposure, activities and tasks, and you can kind of work through something like this. And I think you can put each one of your activities in there. You can put your various areas in there if you want to deal with an area at a time. And then you've got most of the areas that you're going to be looking at is going to be your medium to high exposure risks. Your very high exposure risks are more for the medical fraternity. People like doing post-mortems and working in ICUs and that sort of thing. Whereas, and your low exposure risk will be people more around sort of isolated administrative jobs and that. But I believe that most of your risk is going to come from in the medium or high. But what it doesn't do, it doesn't specifically account for severity. So we know that when you've got COVID, you can have COVID is affixed in terms of the severity. Yes, it gives you COVID, but it's actually not, because you've got this graduation of impact. You've got from asymptomatic, you can carry the disease, you can have it right through to death. So it doesn't actually weigh up that. So it doesn't include like your vulnerability in your groups and all that sort of stuff. So it's something that you'd have to consider in the background of it all. And what I would do is actually manage my vulnerability a little bit outside of this. I would use this for healthy worker type of environments. This is the Apex environmental system that we've got, where we just basically we set the severity and we assume healthy worker. And then outside of healthy worker, we deal with vulnerable workers and that independently in the risk assessment. And then you can see low exposure is infrequent contact at low levels, or moderate exposure is infrequent contact at high levels, or frequent contact at low levels. This is where most of the risk ends up being, unless you actually get like proper amplification points. And then you end up with this like sort of high area of risk. So what's nice about this tool is that it actually considers control failures. Remember, in the hazardous biological agents regulations, you also have to talk about what happens if the control measures fail. And it's important that you stick to the HBA regulations, because they are the regulations that supersede a lot of this stuff, and they give a lot of guidance. So you must always say, okay, this is my risk is medium. How can I get to a low risk? I have to implement more barriers. I must implement social distancing. Then I can have a low risk. But now, if these measures fail, what would be my risk then? Would it be a high risk or a medium to high risk? So it's easy to understand that. So guys, I'm not going to be unpacking this. What I would like to just say is that if you want to look at severity, I can send you this as well. If you ask me to email, and I should have put that in this thing, I can send you the document that guides us on how to select your vulnerability and what is vulnerability. But you obviously leave a doctor or your occupational health nurse to take care of this. So high vulnerability groups, so it's people that are over 65, those with moderate chronic lung disease. But if you look at some of these solid organ transport recipients, cancers of the blood and bone marrow, so then you start going all the way down to your low vulnerability. And I think to get out of vulnerability, I think this is, to me, the crux of everything. This is a direct copy of the prof's slide last week, and it's how you challenge test your workplace. But I retrofit it. So what happens is that if you're actually doing contact tracing and you've got a COVID positive person on your site, what will happen is that you will actually have to do a challenge test to see whether there's only one person, or if there's 3 people or 5 people or 10 people being affected by that work site at all. And within that, if you challenge test it and then you've got a high risk exposure, you will have to implement isolation, testing, and all those other dynamics. What you really want to do is when you actually come across a worker that's COVID positive, you want to be able to say, this is a low risk exposure. If you challenge test that to be a low risk exposure, then your site remains open, then you continue to work. So this is what I use in my own business. This is what I advise for our clients that we service. And how do you retro sort of fit that to your risk assessment? You make sure that there is social distance. You make sure that there is training. You make sure that there is masks being used for everybody. You make sure that when there's a challenge, you make sure that people that work together lunch together within social distance and the barriers. You make sure that people arrive at different times. You make sure people leave at different times. So a very, very important thing for you to be able to understand this one slide. If you can understand nothing else and you understand this one slide and you go back and you challenge test everything and you say, look here, what happens if that worker over there pushing the wheelbarrow tests COVID positive? What impact will it have on my risk assessment on how many people is he going to take off site? Has he got a mask? Is he social distance? Does he have barrier? Does he eat alone? Does he do that? Yes, 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 yes. Okay, so that one person goes home, he gets isolated because you know what? He got it getting to work, or he got it socializing in his community. He didn't get it at the workplace. So that's very, very important for us to understand. And then after that, it becomes a very creative system. So I really hope that you get that and you take that to heart, because it's an important point for me. That was a good revelation that I had. So just pretty much on the final stretch now. So what happens when people are not on our sites? What happens when they're not in our workplaces? This is where they are, often living in cramped conditions, 3 or 4 people living together, no option of any kind of social distancing at all. When they're coming to work, and I've been through these areas. We're actually busy doing some work in Warwick. We've just done some work in Warwick Triangle right now on the second-hand clothing vendors to try and keep them open. But if you look at how they actually work, everybody's got to go into a taxi. Everybody's traveling cramped things. Is social distancing there? No. So everybody has to use a mask. Yes. Is everybody wearing a mask? Let's just say yes. Is all those masks 3-ply, 3-filter, not allowing any of the? Can you blow a candle out with it? That's very unclear, and I'd say largely no. Proven that it's not working like that. So we can expect a massive escalation, even inside when they go about their daily lives on their weekends and all that sort of stuff. This sort of thing is a common picture that you're seeing out there in the different areas. So we have to understand that COVID is ubiquitous. It is outside of our work environment only. So we have to challenge test. If we get a COVID positive case, is FEM going to have to pay out because it's going to be occupationally related or not? Yes or no? You want the answer to be no every time. Am I going to lose more than one person to this disease because of a potential contact? The answer needs to be no every single time. So you need to make sure your measures are in place. Because outside of the environment, this is kind of where a lot of the workforce is interacting. And all we can do is educate our workforce to make sure that they are actually being safe out there and understanding what the risks are. So just in summary, your risk assessment is detail oriented, and it must be the baseline. There is no intervention in COVID-19 and this pandemic that would fail the challenge test of reasonably practicable. Social distancing and risk assessment, every single measure that you can implement is reasonably practicable. So there's no failure in the law, there's no failure in the process, it's only a failure in behavior. So you have to understand the transmission mechanisms to understand what the barriers are and how we can actually stop them. Because folks, this is it's a physical, financial, and psychological disease. So you don't hear a lot of people talking about actually having the disease, but I'm hearing a lot of people around that are getting rumors of people coming and saying, I've got this and I've got that. And when we sit on the task team, we actually get the numbers, and yeah, some of the numbers or some of the experiences are quite crazy. So COVID is everybody's responsibility. It's not just the supervisor, not just the manager. The workforce has to also be completely understand it. So monitoring enforcement remains fundamental, unfortunately. So it's a dynamic process. The infrared thermometers, although widely used, introduce problems into the environment. The NCID do not recommend, or they don't completely recommend the use of the infrared thermometers. They can be used, but they're not part of the challenge test. You don't have to have one on your site. Flushing toilets are now considered a problem. Ventilation is fundamental. Cloth masks and surgical masks are isolation devices. They are not personal protective equipment, and cloth masks are not created equal. Vulnerable workers can work. I'm not going to go through this at all, guys. I think that it's a little bit too much to go through, but if you read through it, you'll see it's just basically a quick guideline to what your key areas are. And I never had an intention of going through it. I put it in just so that when they produce the slides for everybody to have, they can actually go through as a checklist. So guys, this is almost my final slide. We have to understand that COVID-19 is the new normal. This is not going away next month, next year. It's going to be something that we're going to have to live with for a very, very long time. So let's just work together let's just get everybody safe and make sure that we can do this as a way. Everybody that's logged onto the site, I'm sure, is a leader in some way. Be a leader and enforce that. All the tools that I've spoken about, obviously, I just wanted to do a little shameless plug for Apex Environmental. We carry a lot of different things. We're very keen on turnkey. So if you just get hold of us, we'll be able to help you with your risk assessment, edit your risk assessment, help you formalize or guide your risk assessment, right up there to actually supplying you the various types of kit and instrumentation that you need to keep your guys safe. Thank you very much. Appreciate that.
Sean, thank you so much for that very informative talk. I've got a few questions, but before I get to those questions, I just want to ask Gareth if we can launch that third poll question.
Hi, Herman. We're launching poll number 3 now.
Okay, our final poll question for this morning is, please indicate if your organization provides the following resources for COVID-19. That's sanitizer, masks, gloves, and soap. Okay, Sean, just a couple of things that came up. So one of the questions was, there's this conception around masks restricting fresh air. What advice can you give to employers where their employees have to work in confined spaces and there's minimal ventilation?
So in the confined space, you certainly want to throw ventilation in there. You get portable extraction fans. You can use those, and I would certainly do that. And then obviously the harder the manual labor, the higher the breathing resistance of these masks. So they do get uncomfortable, but there's no compromise for them. But in a confined space, you'd often find that an FFP2 is actually an easier breathable and more breathable device than a cloth mask. So maybe because in a confined space, what you are doing with this, you're actually wearing it and you are getting inhalation protection. So you're protecting yourself and you're protecting the person that you're working with. So in terms of that, that would be sort of the best sort of solution.
That's great advice. And okay, this is based on a personal question. What is your view on beards and masks, seeing as you're wearing a beard?
I was waiting for that one. Thank you. I'm having a beard growing competition with my son, my oldest son, who's in Australia. So I can't shave it off. Yeah, you're cutting it down to about 5% efficiency. And that's research that has proven that. So it is really lowering the effectiveness of the device. But do you remember that a surgical mask and a cloth mask is more to protect the projectiles of the talking?
Yes.
Rather than the filtration. If you're using an FFP2 to protect yourself and you've got a beard, it is not working. It's working about 5% of what it should.
Okay. All right, then another scenario that comes up a lot is it seems that transmission at funerals seems to be higher than normal. In your view, is there any particular reason? Is this true, number one, and is there any particular reason for this?
Yeah, social gatherings like churches and funerals have obviously been highlighted because of the raised voices, people singing at the top of their voice, people shouting, talking. Often these funerals and that would have live music or something like that, so people would have to raise their voice. So there's just a hell of a lot more projection, a hell of a lot more production than a workplace or somebody where you're quite sedentary and quiet in the way that you work.
Okay. And then just with transport, I see that you had transport in your presentation as well. With the new regulations and transport allowing 100% capacity, has there been any studies, or do you know how safe this actually is? Is there an increase in transmissions? Or?
There would definitely be an increase in transmission. I think given the fact that there's a rule that all windows need to stay open in the taxi, we know that that's been flouted both in Cape Town and in Gauteng, and I suppose Limpopo, Mpumalanga and all those places. Then there's also the issue of contact time that's in that. So obviously there's a hell of a lot more contact. So if you're normally carrying 4 or 5 people, now you're carrying 15 people. There's all that fomite transmission that's going on in the seats, on the fabric, and there's just a hell of a lot more use. And then finally, the efficacy of the actual cloth masks. And I've looked at them. I went and looked at them in the market at Warwick Triangle. They're not 3-ply anymore. There's a lot of very thin stuff being issued and used. So it's just basically a petri dish for transmission, as far as I'm concerned.
Okay. Lastly, there's been a lot of talks where people talk about the 15-minute exposure before testing positive. How much of the virus must you be exposed to for actual infection?
That's a very difficult question to answer, and I don't even think a virologist could answer it really well. What they're going to say, it's all about dose. So it's not it's really about duration. What they say with the 15 minutes is actually just talking within a meter apart for over 15 minutes. You'd have enough dose traditionally to be able to get that. However, that dose can obviously be accelerated by poor ventilation, lack of masks. You can actually have somebody that's highly infectious. There's actually viral loads within the person that you're communicating with as well. And then obviously if that person coughs or sneezes or raises their voice. So if you go to say, let's just say you want to go to the pub and you're sitting there having drinks and there's so much noise and you're raising your voice, that's obviously going to project more. So it is a bit of a thing. So that 15 minutes is a baseline for talking within a meter to get a dose.
Perfect. Sean, thank you so much for your time. We really appreciate it. Gareth.
Thank you very much, Herman. Appreciate you and your work as well. And I think you guys are doing a great job. Well done for this whole
Thank you.
event. Thank you. Cheers, everybody.
Cheers. Do we have some results there, Gareth?
Yes, Herman, sharing them now.
All right, so we asked, please indicate if your organization provides the following resources for COVID-19. So sanitizer was 100%, masks at 97%, gloves at 61%, and soap at 89%. Okay, we're gonna move swiftly on. We coming to our last speaker for the day. And our last speaker is Kobus van Veenkaart. He's the National SHEC Advisor for SAFSEC. And Kobus is going to talk to us on COVID-19, positive employee management. So just a little bit about Kobus. As mentioned, he is the National SHEC Advisor. He has a master's in science, management of technology and innovation within business management at the Da Vinci Institute. Diploma Management of Technology and Innovation in the domain of operational risk management at the Da Vinci Institute. He's got 15 years experience within the construction sector, including road construction, earthworks, civil construction, and building construction, including manufacturing and mining. He's registered with the SCCPCMP as a construction health and safety manager. And he's developed a risk reduction program assisting companies in the improvement of their SHEC performance. So Kobus, thank you so much for your time. I know you and I have worked a lot together. I'm looking forward to listening to you speak. I'm going to switch off and hand over to you.
Thank you very much, Herman. Thanks for the opportunity. Thanks as well to Sash. Let me just share my screen quickly. Is that clear?
Perfect, Kobus, thank you.
Thank you very much. So yes, today talking to you about COVID-19, positive employee management. So I hope that during my presentation today, I can add to a little bit of value that has already been presented prior to my presentation with today's panelists, as well as the previous webinar that was conducted. By way of introduction into the presentation, I'm going to look at 4 main areas, including the statistics within the civil construction sector, mainly using constructionsector.online information, which I'll give a bit more information about. Risk reduction within COVID-19 positive employee, especially the legal responsibilities when it comes to a positive employee, what employers are responsible for, in addition to the COVID-19 contact tracing and contact risk assessment. So, constructionsector.online. So on Friday, the 8th of May, 2020, SAFSEC launched the constructionsector.online that is an online, free-to-use, mobile-friendly reporting and monitoring tool. This online tool assists contractors, government, and the relevant stakeholders with regards to the information of COVID-19 on construction sites. So designed and developed in-house by SAFSEC, by the marketing division, in addition to the Shirk advisory service. Construction sector.online basically allows you to register your project. You basically enter your project name, the client, the type of project, the contract value, location, and the nature of work that is performed. The daily reporting includes the number of employees and visitors coming onto construction sites, the number of employees and visitors screened, number of employees and visitors suspected to be COVID-19 positive, and what actions were taken. If there were any confirmed cases that results has been received, what actions have the company taken accordingly as well. So to date, a total of 107 companies have registered on constructionsector.online, including 511 projects throughout South Africa, to a total economic value of just over 41 billion rand. If we have a look, so the total screening conducted on site to date, just over 218,000 people have been screened up to date. And if we look at the suspected cases, to date, 177 suspected cases. As you can see, most of them, the total of 149 are in the Western Cape. The total of 29 confirmed positive cases has been reported on the online tool, of which 18 were on projects that were not operational as yet, where the employees conducted pre-site screening and it was found that they were positive. And then there are 11 operational projects where positive COVID-19 test has been received. So moving into the risk reduction. So looking at what our statistics are telling us about COVID-19, and we see it on the news, everybody knows that COVID-19 is spiking a bit, etc. And we expect those figures on the online tool to also be increasing as the days and months ahead of us are coming forth. So when we look at risk reduction, and in linking to what was said before already, COVID-19 being our new norm within not just the construction sector, but every single sector throughout the world, and having a huge influence in the economy, companies with the new norm of COVID-19 have to look at it as one of their new risks. And it's one that's getting a lot of attention at the current moment. But what is important is that during this time, we should not forget about our other obligations in terms of occupational health and safety when it comes to risk reduction within an organization. But similar to any risk that a company faces, we need to have a look. If we want to improve the performance in relation to any risk or the risks involved within either a project or within the company, studies have shown that you actually need to simultaneously affect a couple of aspects. These aspects, as indicated on this graph, includes your physical environment in the workplace, the culture of the organization, with leadership as well, and including the attitude and the behavior of the employees and everyone working within the company. So, as you can see, the graph indicates that all of these aspects are interrelated, meaning that when one aims to amend the behavior and the attitude of employees, you cannot have any positive or long-term effect if there is no effect or change or through the culture and the physical environment as well. So in order to have risk reduction, all 5 of these aspects need to obtain attention. And as previously mentioned during the previous webinar, Garth Hunter indicated during his culture change management presentation, the importance of culture within COVID-19, and that links directly into this as well. So when we look at the role of the organizations during COVID-19, we have got these 4 quadrants, and organizations need to kind of like plot themselves where they find themselves. So the top left front quadrant indicates a walk-in front quadrant. We've got 2 axes. So the first axis, the horizontal one, being our leadership capacity, and our vertical axis, which is our engaged or disengaged, our staff orientation axis. So when we are in the top left quadrant, a walking in front quadrant, is where we've got our staff being engaged and willing to work. Although we've got ineffective leadership within the organization, we find ourselves in that quadrant. In the walking apart quadrant at the bottom left, which is the worst scenario, where we've got ineffective leadership and we've got disengaged staff. Then we've got the bottom right-hand quadrant, where we are talking about the walk behind, where we've got disengaged staff and we've got leadership that is going ahead, and which is very effective. Where we actually should want to be at any stage is the walking together quadrant, where we have got engaged staff with effective leadership. And that is in order to assist us with our risk reduction within our organization facing any risk, even relating to COVID-19. So having a look at those previous 4 quadrants, the top left-hand quadrant, where we've got the bonsai, is exactly, the organization will see some growth, but the growth will be limited within the organization. Or the bottom left-hand corner, where we've got the organization find themselves like in the Dead Sea, where there's absolutely nothing really taking place, where we've got ineffective leadership and disengaged staff. Or where we've got the effective leadership and the disengaged staff. On the bottom right-hand corner, we like the Titanic steaming ahead, possibly moving towards an iceberg. When we're looking at the risks facing our organization, we want to be in the top right-hand corner, as mentioned. We want to be world-class, where we've got engaged leadership and engaged staff working together to a better organization and working environment. So with COVID-19, an important thing within organizations and within risk reduction, one of the things that we need to do is we need to remove the paradigms within the organization. And we need to know that sometimes some of the answers are right there within the organization and not necessarily outside. We sometimes just need to look inwards and find the solutions to a better future for the organization. Moving over to the next part of my presentation regarding the employer legal responsibilities when a worker tests positive for COVID-19. So having linked up with our risk reduction, etc., should the case come that an employee tests positive for COVID-19, there are certain employer legal responsibilities that need to be complied with. I'm going to go a bit into depth with these legal requirements because of the often changing of legislation these days. I wanted to be at this stage kind of be clear what the organization is legally required to do. So the legislation that we are looking at currently is the Disaster Management Act 57 of 2002, including the Consolidated COVID-19 Direction on Health and Safety in the Workplace, COVID-19 disaster regulations issued in terms of the Disaster Management Act, the Occupational Health and Safety Act, Act 85 of 1993, Section 24, that indicates that each incident occurring at the workplace or arising out of or the connection within the activities of persons at work or in connection with the use of plants and machinery in which or in consequence of which any person dies, becomes unconscious, suffers the loss of a limb or part of a limb, or is otherwise injured, or becomes ill to such a degree that he or she is likely either to die or suffer a permanent physical defect, or likely to be unable for a period at least 14 days either to work or continue with the activity for which he was employed for, as is usually employed for, shall within the prescribed period and in the prescribed manner be reported to an inspector by the employer or for the use of plants of machinery concerned, as the case may be. So basically, just taking from that last mentioned, it is clear that the reporting to the Department of Employment and Labour Inspectorate must take place if the worker contracted COVID-19 at work or arising out of or in connection with the activities of persons at work. As required, the employer must investigate each reported case and assess if the worker could have contracted the COVID-19 out of or in connection with the activities of the persons at work. The requirement is, if a case must be reported in terms of quota, is similar if such a disease has arisen out of and in the course of his or her employment. The criteria for determining whether the employer contracted the disease out of and within the course of employment can be summarized. So basically, it is either in the course of employment, means that the accident must happen whilst the employer was busy with his working activities, or out of the course of employment, meaning that the accident must be casually related to his working activities. By this mean casual relationship in the wider sense. Osha Act Section 25 indicates that any medical practitioner who examines or treats a person for a disease described in the second schedule of the Workmen's Compensation Act, replaced by the Court Act, or any other disease which he believes arose out of the person's employment shall, within the prescribed period and in the prescribed manner, report the case to the person's employer and to the chief inspector, and inform that person accordingly. The Occupational Health and Safety General Administrative Regulations, Regulation 8, requires of an employer to, within 7 days of any incident referred to in Section 24(1)(a) of the Act, give notice thereof to the principal director in the form of a WCL1 or WCL2 form, WCL1 being for diseases and WCL2, of course, for injuries. And where a person in the consequence of such an incident dies, becomes unconscious, suffers the loss of limb or part of limb, or is otherwise injured, becomes ill to such a degree that he or she is likely to either die or suffer permanent physical defect because from such an incident. Should report the incident to the provincial director by any means of communication. So basically, moving forward, in terms of the reporting of to the compensation commissioner or the employer individually liable or the mutual association concerned. In the case of a person being diagnosed with occupationally acquired novel coronavirus disease, it must be reported to the compensation commissioner or the employer individually liable, or the mutual association concerned. The notice on the compensation of the occupationally acquired novel coronavirus disease, however, provides more detail and indicates that for the disease to be accepted as an occupationally acquired, the following criteria must be met. As you can see, the occupational exposure to be known source of COVID-19 out of or in connection of the persons at work, a reliable diagnosis of COVID-19 as per the World Health Organization guidelines, an approved official trip and travel history to countries and or areas of high risk for COVID-19 on the work assignment, or presumed high risk work environment where transmission of COVID-19 is inherently prevalent, and a chronological sequence between the work exposure and the development of symptoms. The government notice also provides detail with regards to the method of reporting to be followed. In terms of the investigation of the confirmed diagnosis, the consolidated COVID-19 direction requires, in terms of section 20.11, of the employer must conduct an investigation into the mode of exposure, including any control failure. This assessment will assist the employer to decide if the case must be reported to the Department of Employment and Labour and the Compensation Commissioner, or the mutual association in terms of the quota. Basically to determine if there were any failures within the controls. Section 20.11 furthermore requires the employer also to review its risk assessment to ensure that the necessary controls and PPE requirements are in place, to review the effectiveness of the risk assessment within the workplace. Furthermore, section 20.11 requires the employer to determine the need to temporarily close the affected work area for decontamination using the incident-based risk assessment with due regard to the Department of Health guidelines, and to determine whether there is the need or and the nature of the workplace closure that needs to be decontaminated. Furthermore, section 29 requires the employer to investigate and determine if the worker has been in contact in the workplace with one or another worker and who has been diagnosed with COVID-19. The employer must assess that the worker's exposure in accordance to the Department of Health guidelines to ascertain whether the exposure carries a high risk or low risk of transmission between the workers. I will basically give more indication on that difference between the high risk and low risk, which was also mentioned by Sean previously. So, the legal information was provided by Legricon. Just wanted to thank them for providing us with that. When the recommended procedure for worker testing positive for COVID-19 through the guidelines from the Department of Health includes that employees should be screened for COVID-19 related symptoms prior to the entry into the workplace or the work area at the start of the shift and prior to ending of the shift. Employees to be checked whether they have experienced any sudden onset of the symptoms. Should an employee report any of the symptoms, he or she should immediately be provided with a surgical mask and referred to the designated staff at the workplace so that the arrangements can be made for COVID-19 testing at the closest testing center. Should an employee report any additional symptoms, such as outlined in the system monitoring sheet, he or she should be provided with a mask and referred to the Occupational Health Safety Clinic, a family practitioner or primary care clinic for further clinical evaluation and required for COVID-19 testing if indicated. On receiving their results, the employee and or the health professional supporting the employee should notify the workplace so that the employee is managed accordingly. The workplace should be proactively take steps to obtain this information and avoid delays in reporting. The employee should be managed according to either the scenario 1 or 2 in the algorithm I've outlined below, and which I'll get to soon. And a positive COVID-19 test in an employee will require all potential contacts in the workplace to be assessed using scenarios 3 and 4 in the algorithms also. All the employees on returning to work after isolation or quarantine period should follow general work instructions that include that need to undergo a medical evaluation to confirm that they are fit to work, wearing of a surgical mask at all times whilst at work for a period of 21 days from the initial test. Implement social distancing measures as appropriate in the case of health workers avoiding contact with severely immune compromised patients, adherence to hand hygiene, respiratory hygiene, and cough etiquette, and continued self-monitoring for symptoms and seek medical reevaluation if respiratory symptoms reoccur or worsen. So those are, according to the Department of Health, the recommended procedure for when working testing positive. So having a look at the risk assessment for the work area to determine if we need to temporarily close the area for decontamination. So each organization, of course, could have their own risk assessments. As mentioned before also, that the risk rating is also a variable. And when the organization needs to basically determine that the work area, has it been affected in terms of, is it a low, medium, or high risk area? So for example, the reference for the work area would be the work area, the hazards that could be prevalent in terms of to think about in terms of the contaminated surfaces, the co-workers that were present in the work area where the person has been working that was confirmed to test positive. What was the transmission of the virus possibilities, such as the change rooms, the bathrooms, etc. So the controls that were implemented, such as the area has been closed, or the additional close being the area decontaminated, the hazards affecting the control implementation being the access to the area has been possibly closed, and then indicate whether the area itself becomes an actual high, medium, or low risk according to the matrix that the company uses and the decision that gets taken thereafter. So as mentioned previously, if you've got a COVID-19 positive tested employee, Department of Health basically put together 4 different scenarios. I'm not going to go into detail with each and every one of these scenarios. I actually want to have a look at another algorithm, but these are the 4 algorithms basically provided by Department of Health and is available on their guidelines. In addition to a bit more information on each one of the scenarios indicating what they entail. What I actually want to spend a bit of time on is the algorithms on the slide currently was provided by Osha. And they basically take those 4 different scenarios. They added one, a 5th one, which we will look at briefly. And that basically, and they added in a bit more information, and it makes it very clear for organizations that how to manage your employee, what steps to follow in terms of what direction should you move when an employee tests positive, etc. So scenario 1, with regards to the management of employees with confirmed COVID-19. So now these are employees that's now gone for testing, they've confirmed they're positive. So there are 2 scenarios. Either the employee was not at work and informed the employer, or the employee was at work and was referred to testing because of the screening system that the company included. So if the employee was confirmed positive, the manager is to be notified, the details to be recorded in a contact register, decontamination or sterilization of the work area if the risk assessment determines that, the manager to have daily contact for the full period of recovery with the employee. So with regards to the medical management of the case, if it's a mild COVID-19 case, then basically the person will be in self-isolation at home for the new 10 days after the date of the test. I added these algorithms indicate the 10 days as per the new notice from the Department of Health. If it's a severe COVID-19 case, the person is hospitalized, then self-isolation for 10 days after being discharged. Then if the person is medically cleared by the healthcare professional before returning to work, as the requirements are set, including then return to work procedure to be followed as per the company procedures, and then a surgical mask to be provided for the worker for the next 21 days. Scenario 2 basically covers the management of an employee who present with symptoms compatible with COVID-19. And it basically takes you down the flow chart into the different scenarios that the company could face. I'm not going to go through all of that in detail in the essence of time so that people can have a look at that themselves. Scenario 3, the management of high-risk exposures. As mentioned by Sean previously, our high risk exposure is where we're trying not to be as an organization, being less than 1 meter away from a confirmed COVID-19 case for more than 50 minutes without PPE, failure to use the PPE, or in direct contact with the respiratory secretions. So again, what to do, what an organization needs to do there, and also how to manage the low risk exposure confirmed case of COVID-19. Again, also want to highlight that low risk of exposure cases, if they've got no symptoms, they can continue to work. The fifth scenario that they bring about is the management of employees who do not have any symptoms, but who had exposure to a suspected case of COVID-19. So just in order for employers to know what to do in these ones as well. I want to highlight as well that one thing that we need to take into consideration, we also need to manage our employees in a similar manner within the various different scenarios. If, for example, they are in contact with someone, if one of their family members, for example, is tested positive, then again, the assessment needs to be done. If the employee informs the employer that a family member that lives close by, etc., that he's been in contact with has been tested COVID positive, then we revert to these scenarios and we basically treat them accordingly. So following the testing positive results has been received, as per the requirements that I mentioned previously, the work history for the employee preceding the day he or she was tested for COVID-19 needs to be investigated. As per the slide, you can see that the guidelines from the Department of Health indicates that contacts from the 2 days prior to any symptoms needs to be collected. So that is the indication from them. Various companies do a bit more days than 2 days, but that is the minimum requirement is 2 days prior to the symptom onset. So if we have a look at this, for example, on day 0, when the person went for the test, when did he start his symptoms? So you plot down when did the symptoms start after having this coming out of your investigation that you are doing to determine, okay, 2 days prior to the investigation, prior to the symptoms, sorry, starting, you know, who have the employee been in contact with, and that is where your contacts arise all the way from there up to the date that the employee possibly was not back at work again. All right, the methodology for determining your risk assessment, as indicated, will basically be referred to from the 5 different scenarios. Your methodology will change whether it's a high risk, low risk employee, etc. And with regards to the contact tracing risk assessment that you might be doing. So again, your risk assessment to determine whether it's a low or high risk. I'm not going to go into that with full details. It's been mentioned before, and it is self-explanatory as well. So contact tracing, the contact risk assessment. So for each one of the contacts that's been identified, it is it's a good idea for employees. It's recommended that the employers do a risk assessment on each one of those employees, so that also to determine whether they fall in that high or low category of a contact case. And again, as per the contact description, indicate what kind of contact the people had during the days that the person possibly was still at work, or even, and then also indicate what is the risk rating for that specific contact, so that you can determine the severity and how you need to approach the employee. So, and what measures to put in place accordingly. So I hope that this is informative. Thank you very much. Again, thank you very much to FEM and for Saj for hosting the webinar. Thank you very much to everybody.
Cobus, thank you so much for a very informative session. we've officially run out of time. I'm just going to ask you one question that popped out. I think will be good if everyone could get the answer to that. And it was, what is the difference between screening and testing for COVID-19?
So your screening is basically prior to the employee entering the workplace, or even some companies perform a screening prior to employees actually leaving the premises by means of electronic form, is the actual, do you have any symptoms related? So checking for the symptoms of fever, coughing, loss of smell, loss of taste, and so forth. Where the testing is the actual physical test that only gets done by the medical centers and the approved medical laboratories. So testing does not get done by the employer. Testing gets done by the relevant authorities. The employer only does screening, basically asking the questions: do you have a cough? Do you have a fever? Do you have any of the related symptoms to COVID-19?
Fantastic. Once again, thank you so much. And to all our panelists, a very big thank you for your time, for your contributions today. It's much appreciated. For all of you that have joined on the webinar, thank you all for attending. To Sayosh, a big thank you. To Garrett, to Niels for putting this together for us. Just a reminder that these webinars will be available, all the presentations will be available on the Sayosh website. They will also be available on the FEM website. If you go onto www.fem.co.za and you click on the News Desk tab, you will have access. We will upload as soon as it is ready. So from FEM, we'd like to wish you a good day today. And once again, thank you to everybody. Bye.